I welcome all of you for the today's 17th annual conference. We have three academic sessions today. We have a head and neck oncology session, then colon cancer session, and the panel discussion on early lung cancer, followed by the quiz session and the GBM. So we'll start with the head and neck cancer sessions. We have esteemed faculty from outside and from the Northeast also. I will ask my senior resident, Dr. Devakor Chirmang from NIGRIMS, to take over and start the session. Devakor, you are there?
Yes, sir. I'm here, sir.
You can start. Yeah, start the session.
Thank you. Good evening to all the esteemed attendees of the 17th Annual Virtual Conference of AONEI, and welcome to the session on head and neck oral cavity cancers. I'd like to welcome the chairpersons of this session, Dr. Suvamoy Chakrabarty, who is the professor and head, Department of ENT, NIGRIMS, Shillong, Dr. Kudush Ahmed, who is the consultant head and neck oncosurgeon and head and neck surgeon at Dispur Hospital, Guwahati. He's also a senior AONEI member and a previous president of AONEI. And last, Dr. Chanmiki Sayo, who is a consultant head and neck oncologist at the Woodland Hospital, Shillong. I'd like to hand over the rest of the session to the esteemed chairperson. Thank you.
Thank you for having invited us for chairing this. Dr. Subhamay, shall I start?
Sir, Suvamoy sir will be joining after some time. He's stuck up with something, so he asked you to continue the session, sir.
Okay, so the first talk is by Dr. Prathamesh Pai. A short introduction of Dr. Pai. He is professor, Department of Head and Neck Oncology in Tata Memorial Hospital, Mumbai. His special interests are in laryngeal and skull-base surgery with focus on laser and minimal access. Today we'll be talking on surgical approach in high ITF tumors. So high ITF tumors are traditionally non-surgical approaches, but today we'll listen to what Dr. Pai has to say about surgery in high ITF tumors. So Dr. Pai, please.
Yes, sir. Thank you very much for the invitation. And at the outset, I would like to clarify that, as Dr. Ahmed said, high ITF tumors are something that we would not consider operable. But this is a talk on approaches to the ITF tumors in oral cancers. So we all know that head and neck tumors form 30% of the Indian cancer burden. And when you look at these oral cancers, the gingivobuccal sulcus cancers form 60%. And most of them, 75%, are stages 3 and 4. So when you look at this problem, we know that these tumors are aggressive. The advanced stage survival is 30 to 40% at the most at 5 years. And surgery and the survival is determined by surgical clearance with good margins, neck nodes at presentation, and the adjuvant therapy that we give. Now, when we look at advanced cancers, the stage 3 and 4 usually comprise of the T4A and the T4B tumors. And the T4B tumors are the very advanced local disease, which involve the masticator space, pterygoid plates, skull base, or encasing the internal carotid artery. So the lymph nodes we are aware of as they become larger, and as they have an extra nodal extension, they become more advanced. Stages 3 and 4 are treated with combined modality treatment, usually surgery followed by radiation or chemoradiation. So if you have to aim for a cure in advanced stages, we need to triage out a curative case. We need to ensure adequate margins, and we need to deliver timely adjuvant therapy. So let us focus on the clearance of these diseases. As I mentioned, gingivobuccal sulcus cancers form the predominant cancers in oral cancers. And they usually present such as these innocuous looking diseases, but they're very advanced in their superior extension and the nodal extension. they have late presentation because of these small apparent lesions. So it's very incumbent on us to actually get a good evaluation CT scan in order to look at the infratemporal fossa for involvement. Now, a curative case is when you can have a possibility of margins. There shouldn't be gross perineural spread. It should not involve the high infratemporal fossa and the pterygopalatine fossa. And there should be less than 180 degrees contact with the common or the internal carotid artery. Now, generally, when we are taking up a patient for surgery, what do we need to ensure? We need to ensure that we get a proper R0 clearance. The minimum margins should be 5 millimeters. Our resection should be 3-dimensional, and we should get a resection with negative margins on the specimen. We are all aware that as the margins increase, the survival improves. For this study showed that every millimeter increase reduced the risk of death at 5 years by 8%. Then coming to the unresectability. What is the criteria of unresectability? Adequate surgical margins are not achievable. Extensive ITF involvement, involvement of base skull, and extensive soft tissue disease. So a common trend you are seeing that the ITF involvement has a poor prognosis and it's a very, very high stage disease. So is this cancer that we are seeing just because of ITF involvement unresectable? Most of us will deal with this on a day-to-day basis. So it's very important to understand why is this infratemporal fossa a bugbear of the head and neck surgeon. These tumors are involving a space which we are all aware is triangular in origin and is bounded by the skull base and laterally and medially by the mandible and the nasopharynx and lateral pharyngeal wall. However, what we realize, there are no boundaries. There are no barriers to the spread of disease in this space. And hence, it can easily go into the pterygopalatine fossa from wherein it can enter the skull. So our concerns for a surgeon in this, when the tumor enters ITF, is that are we able to get a local control? What about the perineural spread along these foramina? And can we actually ensure a complete removal, or we'll end up with a residual disease? Now, there are two types of infratemporal fossa involvements. One where the patient presents with trismus, involvement of the mandible and the maxilla, and there is involvement of the soft tissue in the infratemporal fossa above the notch. The other variant are the ones that are more common, where the patient has a relatively normal mouth opening. However, the disease involves the masticator space, but is below the level of the notch. So there was a group from Taiwan that initially proposed the supranotch and infranotch involvement. So they grappled with the possibility that is T4B disease resectable. And they laid out all these problems that we know are there in when we are looking at T4B. So they reasoned out that from the notch, you will get about 2 centimeters of margin from the skull. And that is adequate when you are looking at clearance of disease below the notch. They found that higher the number of structures in the infratemporal fossa, such as the masticator space and the pterygopalatine components, more is the possibility of failure. Closer to the skull base, inadequacy of skull base of surgical resection. And higher incidence of lymph nodes and perineural spread when the disease is going into the high ITF. They also found that the T4B had locoregionally and overall survival better in the infranotch disease. And when there was no nerve invasion or no nodes, they did as well as the T4As. So they said that selected T4B were resectable with outcomes similar to T4A. Our own center at Tata Hospital looked at our T4As and T4Bs, and they found that the nodal disease seemed to have a huge bearing. So if your patient had a T4A or a T4B with nodes, they had a poor survival. So we looked at the T4 buccal cancers, When you look at the T4As with node negative and the T4AB with node negative, they did relatively as well. If they were infra-notch, they did exceedingly well as compared to the supra-notch. Another issue was, can we get a margin clearance? So when we looked at the T4A and B, we found that adequacy of margin was not a problem. Most of the patients, we could get an adequate margin when we had a proper case selection. What was different was that in the patients who were T4B with nodes and who had closed margins, they had a 2.5 times more possibility of failure. So what is important to realize is that in infratemporal, we need to clear the entire tumor or in the masticator space along with the nerve and as close to the greater wing of sphenoid. This is a complex anatomy, but what we need to understand is that the central structure here is the internal maxillary artery. And when we control this vessel, we will reduce the bleeding, which is the problem why many of us cannot clear this disease adequately. So another point in this, which was brought out by Monique Kuriakose in his paper in 2008, was that the infratemporal fossa has to be separated from the petrotemporal fossa. So when you looked at this anatomy, as the disease goes from anterior to posterior and it comes on to the petrous apex, this becomes relatively inoperable. So this is a typical case that we will look at: the gingival buccal sulcus cancer, external skin fungation, and involvement of the mandible with trismus. This is the specimen that we need to get, a complete clearance with the masticator space, with the skin and the entire tumor. So how do you achieve that? You will want to clear this from the skull base, and this is the magnified view where we are seeing the posterior lateral wall of the maxilla and the pterygoid plates and the complete clearance from the greater wing of sphenoid down to the pterygoids. So the key is control of bleeding and clearance from skull base. So we need to understand that our resection cannot go beyond the foramen ovale, because beyond this, we will not get a complete clearance. We will always leave behind microscopic residual disease. So all the structures that we need to clear are the lateral pterygoid plates, which are coming from the greater wing of sphenoid and the pterygoid plates, as well as the medial and lateral pterygoid muscles. So the most important thing is control of the bleeding. You have to take the internal maxillary artery at the level of the neck of the mandible. This is how you will clip it. You will access the vessels and clip the vessels here. This completely devascularizes the ITF contents. Then you need to do a capsule separation. You need to separate the capsule from the glenoid fossa, and this separates the bone from the infratemporal fossa. So you see that the condylar head, we have to go along the condylar head, come onto the glenoid fossa and clear that, which separates the mandible and now remains attached only medially. This is how you will get the bare glenoid fossa and clear that tissue off the bone and go along the bone, greater wing, coming down medially. Once you have cleared that, you will see the attachments of the lateral pterygoid from the greater wing as well as the medial pterygoid. We will have to then clear this from medial to lateral. So coming from the pterygoid plates down towards the center. Now in the infratemporal fossa, the key is the foramen ovale. So it is the center point. So from lateral, from the glenoid fossa, you go work towards the foramen ovale. And from the pterygoid plates, you work laterally towards the foramen ovale. And finally, you will have a complete clearance from the greater wing of sphenoid down. And this will be how the entire specimen will be divided, separated out. That is your pterygoid plate, the articular eminence, and this is the foramen ovale. So infratemporal fossa may be accessed with surety. Not all T4B supranotch are inoperable. The supranotch squamous cell cancers need to be carefully evaluated and separated out. Try a suitable candidate, one who has no neck nodes, one who has no perineural spread with minimum bone and skin involvement. And the resection in T4B should be attempted with lesser number of the pterygopalatine structures involved when there is a N0 or N1 status and when there is a well to moderately differentiated cancer. Thank you very much for a patient listening.
Thank you, Dr. Pai, for giving us a brief overview of these infratemporal fossa extension of oral cancers. So we are already, do we have time for questions here?
Sir, we can take at the end of all the sessions.
Okay, so we'll go over for the next speaker then.
Yes, sir. I think Dr. Sayo is there, na? Sayo, you can pick up. Dr. Chinmiki?
Hello, can you hear me?
Yeah, we can hear you.
Yes. Thank you, sir, for that brief and nice discussions on the surgical approach on the high ITF tumor. And after the surgeon part of view, now we will come with a little bit about the chemotherapy and metronomic therapy in our cancer. And I welcome Dr. Sumit Goyal, sir. Please, sir, proceed with your session. Regarding the management of oral cancer regarding chemotherapy and with metronomic therapy. Goyal sir, he is a medical oncologist practicing in Rajiv Gandhi Cancer Institute, Rohini, Delhi. So please, sir, I hand over this sessions to you now.
Good evening, everyone.
Yeah, good evening, Sumit.
Hope my slides are visible. I'm audible. I'm still sitting in the OPD. So
Yeah.
permission to proceed, sir?
Yes, please go ahead,
Yes,
Sumit.
So the topic today, which I have been given, is chemotherapy and metronomic therapy in head and neck cancers. So it is a very vast topic, not easy to cover in a single session of 15 minutes, and it requires a lot of discussion and so many intricacies are there. Still, I will try to cover as fast as possible in a brief manner. These slides have been collected from various sources for educational purposes, no copyrights of mine, and just proceeding further. So we know head and neck cancer is a heterogeneous subgroup of the tumors. It occurs in various sites. 95% of the cancers of the head and neck are situated in the oral cavity, oropharynx, hypopharynx, larynx, nasopharynx. Other anatomical sites are also there, paranasal sites, salivary gland and lip. So if we look at patterns of failure post-resection, we see in resectable tumors only after surgical resection it is close to 40%. And after adjuvant RT it is close to 30%. If we combine from chemoradiation, then it is approximately 20%. And if we look at pattern of failure in the locally advanced commercial cancers after single modality therapy, that was in the resectable tumors, this is locally advanced. So we see that the rates of failure increases 50 to 60% at 2 years, and failure at distant sites is also there, which increases from 15 to 20% at 2 years. So we know the content chemoradiation protocols, they improve local regional relapses and they also impact on distant failure, but the results are inconsistent and we don't have accurate predictive markers to predict the outcome. So if we look at the meta-analysis, so we can clearly see adjuvant chemotherapy trials, they have very minimal benefit on the outcome. And induction also have not been consistent in the outcomes. And if we see the concomitant portion, so here the absolute benefit at 5 years was close to 8%, which is like a good increase from in the control rates. So same here, if we look at the McKenzie update, we can see the age matters. In the younger patients who were younger than 50 years of age, there was approximately 24% increase in survival. And as the patients they get older, the increase in survival decreases. It may be offset by various other factors, or it may be due to the disease biology. The increase was close to 3% only. So if we look at induction therapy protocols, so usually we use cisplatin or 5-FU based, which is the most commonly used induction therapy regime. And the cisplatin versus 5-FU or carbo versus 5-FU, the responses were different numerically, but statistically they were not significant. However, numerically it was 92 versus 76%. And PF was cisplatin 5-FU was associated with improved survival as compared to carboplatin plus 5-FU. We use these protocols either in palliative or along with concomitant radiotherapy, but nowadays along with concomitant radiotherapy, we are not using these protocols. So if we look at randomized trials of induction chemotherapy along with taxanes, we see taxane 323 and tax 324 studies, which had included patients who were locally advanced. The response rates were good, and 2-year PFS in tax 324 was 53 versus 42% in terms of this, and overall survival was 70 versus 30%, which was statistically significant also. But this was comparing the two arms only. It was, and tax 323 again, there was 3 years benefit of 24% versus 18% was there. So these are the studies which have been done in patients who were previously untreated head and neck cancers. So if we look at chemotherapy per se, so the single agent chemotherapy, the several single agents have been used and they have significant activity, but there is no standard single agent for therapy for advanced head and neck cancer. The most commonly used drugs include methotrexate, cisplatin, carboplatin, paclitaxel, docetaxel, and 5-FU. So the one trial which compared BSC versus bleomycin versus cisplatin. So this study concluded that cisplatin improved survival compared with best supportive care by 10 weeks, and cisplatin was better than bleomycin or methotrexate. So cisplatin monotherapy was started, and it was at least as effective as the platinum-based combinations. If we look at response rates of the different single agent chemotherapies, so we can see either the taxanes or the cisplatin, they have the highest responses, close to 21 to 42, close to 40%, and taxane again, paclitaxel same. Apart from that, it ranges from 3 to 15%, whether it is capecitabine or fluorouracil or methotrexate alone. So summarizing single agent therapy, direct comparisons of efficacy are limited by paucity of randomized trials. Most patients are treated with combination chemotherapy, and choice of chemotherapy agent depends upon patient's clinical status. And general principle combination chemotherapy, prior to 85, we had various combination of cisplatin, methotrexate, 5-FU, and bleomycin. And usually the cisplatin based combinations were most commonly used. There were 6 large randomized studies. So these were the studies in various combinations, which consisted of cisplatin, methotrexate, bleomycin, vincristine in different combinations. The response rates in all these studies, they range from 10% to up to 48%, but they had very heterogeneous sub patient population, and they were all like in older days. We don't know whether it can be replicated today. So cisplatin 5-FU forms the baseline for today's chemotherapy backbones if we have to use in neoadjuvant setting. So platinum analog plus taxane plus either cisplatin or paclitaxel forms the backbone of neoadjuvant chemotherapy as of today. So if we look at the response rates, again in the taxane group, it is 32 versus 41% as compared to cisplatin 5-FU versus carboplatin 5-FU. So toxicities, we are all aware the toxicities are more in the cisplatin 5-FU group. So again, the same studies. If we look at other studies, these are combining the biologicals also. So if we look at trials which have shown data, which is mono versus polychemotherapy, we can see the cisplatin 5-FU versus cisplatin versus 5-FU, though the response rates were different, the median survival was almost same. So if we look at the randomized trials with taxanes, again, whether it is cisplatin 5-FU versus paclitaxel, the response rates are closer and median survival is almost similar, but toxicity profile differs. So if we look at chemotherapy options in recurrent metastatic setting, this is what NCCN says. We have to use either pembro, monoclonal and this checkpoint inhibitors along with chemotherapy backbone depending on the CPS levels, or we can use targeted therapy like cetuximab in combination with taxane with 5-FU and cisplatin, or different combinations of taxanes with cisplatin or 5-FU. Same thing here in ASMO guidelines. Depending upon the scenario, PD-L1 levels, patient's fitness, we can choose between checkpoint inhibitors or combination of checkpoint inhibitors with the chemotherapy backbone, or chemotherapy backbone with targeted therapy, or chemotherapy alone or single agent chemotherapy, depending upon this thing and the patient's fitness. We will look at the molecular biology and the targeted therapies. So we have monoclonal antibodies like cetuximab, which has shown benefit. Others have not shown any benefit. And tyrosine kinase inhibitor, gefitinib, we have seen either 250 or 500 did not make much of a difference. Now, erlotinib in combination with oral metronomic chemotherapy is showing promising results. And if we look at the biologicals with chemotherapy arm, this was the study which changed the paradigm, extreme study. There were two groups, cetuximab plus cis or carbo with 5-FU, and the group B consisted of only without the biological. So the 6 cycles were given in arm A followed by cetuximab maintenance. So this had shown a benefit of 2.7 months in the Erbitux arm. So this had become the standard of care at that point of time. So this study resulted in 36% improvement in OS, and there was prolonged PFS. But it had toxicities. It was difficult to give and cumbersome because cisplatin 5-FU need to give for 3 to 4 days continuously. So TPX, whether we can substitute. So this was the study which compared the extreme with TPX. So it had cisplatin 5-FU cetuximab versus docetaxel and cetuximab in the same arm. We look at the survival data. So these had shown the results were almost similar in both the arms, and the toxicity was lower in the TPX arm. So TPX arm has become now standard as compared to extreme arm, depending on the toxicity. If we look at the checkpoint inhibitors in head and neck cancers, so we have various drugs like Nivo, Pembro, Atizo, Durva, and Evolumab, but only these two are approved. That is Nivo and Pembro are approved in head and neck cancers. So Checkmate 141 was the study which was used in recurrent metastatic head and neck cancers after platinum therapy. So 2-to-1 randomization, Nivo 3 mg per kg 2 weekly versus investigator's choice of drug, which consisted of either methotrexate, docetaxel, or cetuximab. If we look at the results at 12 months, the curve started to separate later. But if 12 months later, we see there was quite a bit of separation, and the patients who responded, they were continuing to respond. And the median OS was 7.7 months as compared to 5.1 months with a hazard ratio of 0.71, and response rates again to the tune of 13.3 versus 5.8 months. Then the other study, Keynote, consisted of Pembro, again in platinum who have failed platinum, the Pembro and the standard of care, the primary endpoint was OS, and crossover was not allowed in this study. If we look at again median OS of 8.4 versus 6.9 months, significant p-value, hazard ratio of 0.80. So if we look at OS Keynote 041 OS by PDL expression, so if we can clearly see if expression was more, the likelihood of benefit was more, 11.6 months versus 7.9 months, and response rates of 46.6% versus 25.8%. And this was the Keynote 048 study, which was done upfront. Depending stratification factors was PDL1 expression levels, and it was There were 3 arms, 1:1:1 randomization, Pembro plus chemotherapy, or cetuximab plus cis-5FU, which was the extreme arm. So here we can see if the CPS score is more than 20, then Pembro versus extreme arm, the clearly median OS was better in the Pembro arm, 14.5 months versus 10.7 months. And if CPS score was more than 1, even then, though the magnitude was not that much, but still it was better as compared to the extreme arm. So same thing with the chemotherapy arm, median OS of 13.0 versus 10.1 months. But in palliative systemic therapy in head and neck cancer, actually chemotherapy alone has not improved the survival. Still, we are in dilemma whether to give single agent or combination. Standard was extreme, but Keynote 048 has become the new standard. But it is an issue for us in low and middle income countries. So we need to have another something in our armamentarium. So oral metronomic therapy comes into play here. So metronomic therapy is basically frequent administration of chemotherapy drugs at doses below the maximum tolerated doses with no prolonged drug break. So mechanism of action, it exerts the direct and indirect effect on the tumor microenvironment. It accesses tumor angiogenesis and stimulate anti-cancer immune responses and induces tumor dormancy. So briefly the same thing. So I'll skip this. So there are 2 main clinical settings for the use of metronomic study in the squamous cell cancers of the oral cavity. One was used in the adjuvant maintenance therapy after curative intent. Other was in the palliative therapy in the recurrent and metastatic setting. So quickly in the adjuvant setting, there were 3 studies done in, this was a study with oral tegafar uracil as a metronomic therapy done in stage 4 and 4B of the oral cavity. Here, the authors have said that adding this uracil tegafar to CCRT significantly improved the DFS and OS rates in patients with non-distant metastatic stage 4. This was following the definitive treatment, but whether these can be replicated today is difficult to know. So these are 2 other studies which have been done in adjuvant and clinical study. One was with the use of S1. Here also the authors concluded that the 3-year DFS and 3-year survival rates were 82.6% and 94% respectively, which is quite impressive. So another study which was done in the adjuvant setting that consisted of tegafar and uracil based. But I don't think we don't practice this as routine. So in recurrent and metastatic setting, again, there are 3 studies. One is afatinib versus methotrexate based on the phase 3 study of Lux Lung Head and Neck 1. This study showed afatinib was associated with significant improvement in PFS survival, and it had a manageable safety profile. So other 2 studies were from Tata Memorial Hospital in Mumbai from Vijay Patel and Vanita Norona group. So first they had done the phase 2 study, which had shown it was effective. And based on this results, they had conducted the phase 3 study. So this is the phase 2 study results. They have shown PFS had improved from 101 days versus 66 days, and low incidence of grade 3 side effects was there. So this was a schema of their study. Cisplatin versus oral metronomic was compared. So basically in this study, majority of the patients were from the oral cavity cancers. So the results were at 6 months. The 6 months overall survival in the intent to treat population was in the metronomic therapy, it was 62.26% patients had compared to 50.89%. So there was difference of close to 11.37% patients were doing better. So based on this encouraging results, we in our country are slowly adopting this protocol. If we look at metronomic versus other palliative therapy the median OS was 7.5 months, whereas in the chemotherapy arm, it is comparable, 7.4 to 8.7 months. In oral cavity cancer, the response rates are close to 77% in oral metronomic therapy as compared to less than 30% in the combination chemotherapy arm. And if we look at oral metronomic therapy, the median OS is 7.88 months as compared to 4.4 months in the chemotherapy arm. And the toxicity much less and very well manageable. Cost, we cannot compare the cost, it is negligible versus the significant. So based on this, in coming days, slowly we are shifting to oral metronomic therapy in recurrent and metastatic setting, which I think is the need of our country till we can have better options available to us. With this, I'll stop here and I'm stopping my screen share, sir. Over to you, sir.
Thank you, sir, for that brief discussions about the role of chemotherapy and metronomic therapy in oral cavity cancers. As it has been said earlier, the questions and answers will be taken at maybe after the end of this next session. So straightforward, we will go to the next session. That is the role of radiotherapy in oral cancers. What are the precautions? What are the cautions that is necessary to be taken during this radiotherapy in oral cancer? So I welcome Dr. Sayan Paul from Apollo Kolkata. Please take over this session regarding the role of radiotherapy in oral cavity cancer. So Dr. Sayan Paul, he is a senior consultant, radiation oncologist in Apollo Hospital in Calcutta. So please, sir, this session is yours now.
Good afternoon, all. At the outset, I thank my friend Dr. Vikas, Jagtap, and the organizers for not only inviting me in this seminar, but also for choosing this topic. This topic is a very important topic, but it is very rarely discussed in meetings. So I'm very glad that this topic has been chosen by Dr. Vikas. And in my presentation, I will not be showing any trial. I will not be analyzing any data. I'll just discuss the practical aspects that we encounter every day in our clinic and during our radiation planning. I apologize because it might be a little bit of boring for the senior radiation oncologists who are doing it every day, and for my colleagues from other specialties, surgical oncology and medical oncology. But I found it so much interesting that I kept it very practical and very short. And at the end, I'll request you to put your comments, and if you want to add something in this, please add it so that our younger colleagues can learn better. So as we all know, in oral cavity cancers, radiation is a very important modality. So it is very important for cure, and in most of the cases that we see in our clinic, they need radiation, either as a radical treatment or mostly post-operative treatment. So we rarely see very early cases which does not need post-operative radiation. Most of our cases need post-operative radiation. So, and it's a very common cancer, and most of, I think, in India, in our clinic, so almost 30 to 40% are head and neck cancers we treat. And though it is very common, it is, I feel, among all the sites, this is a very tricky site to treat. There are many issues when we are discussing about head and oral cavity radiation. So the topic is the caution and precautions. So there are some for the treating radiation oncologists, and there are some for the patients and the caregivers. So the first one is for the radiation oncologist. Before we start planning radiation for any oral cavity cancer cases, be it radical or post-operative, before starting, we need to assess the nutritional status and intake of the patient, because poor nutritional status is actually very commonly seen in these patients. There are various reasons for that. This is disease related because there is a mass or an ulcer inside the mouth. They cannot take food properly. They cannot chew the food properly. There can be cancer related cachexia. There is swallowing difficulty because of the tumor, because of the mass, and it's long standing usually. And these patients are usually tobacco chewers, so they have limited mouth opening, and that also causes difficulty in eating. And for I have seen patients for years with very minimal mouth opening, they are managing somehow with liquid food or semi-solid foods. And the post-op status, because many patients are post-operatively, it's very difficult for the patient to start proper nutrition. They are mostly tube fed, or if they start oral feeding, that is also difficult with the flare or a reconstructed tongue or the surgical scar. It is difficult for them to take food. And the taste also alters if half of the tongue is not there or there is big surgery inside the mouth. There will be alteration in the taste. Salivation also changes. And with that, if we add radiation therapy, so we convert dysphagia to rhinophagia. There will be pain when swallowing. There will be mucositis inside the mouth and the throat, which will again aggravate the situation, will again decrease the nutrition of the patient. There can be dry mouth. The saliva quality changes. It becomes very thick, becomes sticky. It makes life very difficult for the patient. And its patient decreases food intake. There can be some swelling also associated with radiation, and there is taste changes obviously. And in some patients, when chemotherapy is added along with radiation therapy, it makes it more difficult with nausea and vomiting, less appetite. So before starting radiation planning or chemoradiotherapy planning, we need to ensure adequate intake. So we can do it by encouraging oral feeding as much as possible, giving proper dietary instructions. We can give tube feeding. Suppose post-operatively, if the patient is having a nasal tube, we encourage them to keep the tube in situ and we will give oral tube feedings. And if required, we might have to give some IV fluids also. So before starting radiation, we can encourage them to do some swallowing exercises like the tongue hold exercise or Masako exercise. That is, we'll ask the patient to hold his or her tongue in between the front teeth and keeping the tongue in that position. They will try to swallow. That is the tongue hold exercise. Then effortful swallow exercise. That is a normal swallowing, but at the time of swallowing, the patient contracts the muscles forcefully. Or Mendelssohn swallow maneuver exercise. When the Adam's apple goes up, we ask the patient to hold it for 2 seconds and then relax. Then there are some tongue exercises, tongue protrusion exercise, like protrude the tongue as much as possible, tongue lateralization exercise, or tongue retraction exercise, as much as the patient can do. They should start doing as early as possible when the surgical scar is big, or if it is non-surgical case, before the planning on the first day of consultation, you can ask the patient to start doing that. Christmas is also associated in many of the cases because many of them are tuberculous. Christmas is long-standing. Christmas can be disease-related. Christmas can be post-op. So to manage that, the jaw exercise should be started, like opening the mouth, moving the jaw to one side, moving the jaw to the another side. And an important thing is the passive stretching exercise, like placing the thumb in the top teeth and the index finger in the teeth in the bottom of the front teeth, and then trying to open the mouth and a little bit of stretch without giving any pain. And patient can hold it for 15-30 seconds. And as you know, the practicing radiation oncologists, that there are instruments for this jaw, to doing this jaw opening exercises. And if you want a cheaper version, then you can use ice cream, these wooden sticks for eating ice creams, and they can stack them up and put as many as possible between the two jaws and try to increase the number every day. This will help them to opening up the mouth. And the dietary counseling, which is very, very important, and instruct them to take only soft and liquid diets and not to take anything which has sharp edges like potato chips or almonds or nuts, because these sharp edges can cause injury inside the mouth or in the throat and can aggravate mucositis and the swallowing difficulty. They should take non-spicy food because spicy food can cause irritation inside the mouth can aggravate the situation. And to avoid citrus fruit, which can cause irritation inside the mouth. And we need to remember that our oral cavity patients will not be able to take food like we take 4 times a day or 3 times a day, breakfast, lunch, evening snacks, and dinner. So they have to take small frequent meal. And very a useful thing is to make a schedule, a routine, a time schedule that from the morning up till they go to the bed. So according to a fixed time schedule, they will take small frequently, maybe 8 times, 10 times or more. So in this regard, I remember our teacher, Dr. J.P. Agarwal, used to ask the patient to write down in a notebook whatever they have taken since morning and throughout the day. And they have to show this to us in the OPD, to check what food and how much they have taken throughout the day, and if the nutrition and if the intake is adequate or not, and then we could we could advise them accordingly. So fluids should be taken adequately so that the patient remains hydrated, because if they are dehydrated, there will be more dry mouth, there will be again less intake, there will be difficulty in intake of food, and it will aggravate the situation. So hydration is also important. We need to encourage them to do adequate fluids. And if you feel that they need nutritional supplements, you can prescribe that also. So feeding usually will encourage enteral feeding, oral feeding is encouraged. And nasal tube is a very important and a useful thing, because after post-operatively, many patients, because the surgeon only puts nasal tube after the surgery, and when it comes for radiation planning, I usually encourage my patients to keep the nasal tube. Many a times they say, please remove this because it is so uncomfortable. So I try to motivate them to keep the nasal tube throughout the radiation treatment and after that for some time. So to ensure that if the patient doesn't take orally, we can feed them with the nasal tube. And peg tube also very, very, very useful for keeping the proper nutrition. There is an article by Professor Shalin Kumar from SGPDI, and in that they had done inserted peg tube for all the patients they have treated, and they compared with the patient to encourage oral feeding, and they have seen that the nutrition could be maintained with peg tube much better, and the compliance is also very good. So if the patient agrees and if you feel that you have the facility, you can discuss with the patient and you can try to put a peg tube for the treatment. And then next one is the dental checkup. So if there is a sharp irregular teeth, the teeth that should be fixed, and so that it doesn't cause any injury inside the mouth and increase the mucositis on or make it difficult during the radiation treatment. If there is any dental infection present, we need to treat it before starting radiation, because these infections can worsen the mucositis and worsen the swallowing difficulty during radiation, and can make it very difficult for the radiation oncologist to complete the treatment. Fluoride application, which has been seen very useful, and if the patient is using a denture or any prosthesis and if it is ill fitting, we need to fix it. And we need to encourage the patient, if it can't be fixed, then use it as less as possible and keep it outside the mouth most of the time. And there is some issues with tooth extraction, because there are sometimes there is tooth decay or caries tooth and a very bad tooth, and the dentist advises extraction. But we need to keep in mind that if the tooth is extracted, we can't start the radiation immediately. We have to give adequate time for healing the wound. So usually it is not less than 2 to 3 or 4 weeks sometimes. We can't start radiation, but if it is absolutely necessary, we have to do it. Another important thing is to explain the side effects and the course of the treatment before starting, because if we don't explain at the beginning and after 2 weeks, the patient starts having mucositis or difficulty in swallowing, they get really scared. I'm not telling to scare the patient, but to motivate them and positively inform them about the course of the treatment, when they can expect which side effects, like after how many days or how many weeks of treatment, which side effects appear and how it evolves, like how suppose the mucositis increases over the time, or the difficulty in swallowing or the pain in the swallowing increases over the time. And also at what time it will start decreasing and around what time it will dissolve. So if they know it beforehand that yes, after 2 to 3 weeks, I'll be starting having mucositis and I'll be having difficulty in swallowing. But after completion, within 1 week to 10 days time, it will start decreasing, and within 4 to 5 or 6 weeks time, it will be completely resolved. They will be assured that yes, it is quite normal with radiation treatment, and it will ultimately resolve, and this is temporary, and a day will come when I will forget about these acute reactions. And we need to explain them that yes, there is need of tube feeding. So I see many radiation oncologists who routinely prefer tube feeding. So we need to explain to the patient, even if they are not ready for tube feeding at the beginning, in the beginning, during the treatment also, we might have to insert nasal tube and have to give feeding. We need to admit the patient for a few days, or we need to give IV fluids in the daycare, and we need to do some blood testing in between. If we explain them before starting the treatment without scaring the patient will be reassured, and patient will be able to cope the treatment very well. Another important aspect that we often forget is the psychological counseling, because the diagnosis and treatment of cancer is actually a very stressful and overwhelming event. So this associated with anxiety and depression, anxiety about one's life, fear about one's life that I might die in next few months' time. Their anxiety about the finances, financial crisis. There is anxiety about interpersonal relationship with the spouse and the family members. And they might have anger, they might have suicidal tendencies, they might feel helpless, they might feel very, very frustrated. We need counseling by an experienced psychologist. So though we are physicians and we are seeing them every day in the clinic, we are not properly trained to identify the psychological crisis they are having. It is an experienced psychologist who can actually counsel the patient, and who can actually determine what is the problem they are having, and they can help them really with their counseling session, but medication is required. So we need to encourage them to join the support group. If they talk to other cancer patients or cancer survivors, they'll be motivated. They'll get to know that yes, there will be some problem during the treatment, but ultimately we'll overcome this problem. These problems will dissolve, and we live a normal life. And even after the treatment of cancer, we can live a normal life, and the society also accepts us. So we encourage them to do some relaxation and meditation exercises, yoga, and de-addiction is also very important, because most of the lung cavity cancer patients are addicted to tobacco or smoking. We need to do a psychological counseling, and we need to send them to do a de-addiction center, because we don't want the disease to come back. They need to stop taking tobacco, they need to stop smoking, or if they have any other addiction, they need to stop that. So during simulation, we need to follow some basic things. I'm not describing the simulation process in detail, but a little bit of one or two issues that we usually face. I discussed that only. That we use a thermoplastic mask that should cover the shoulders. So don't use a small 3-clump brain mask. We use a 5-clump mask or this type of mask which covers the shoulder. And please do a contrast scan if it is not contraindicated, because without a contrast scan, I don't think it is like you can't control the nodal volumes, or you can't see the tumor properly without a contrast scan. Because nowadays, as we are doing mostly image-based treatment like IMRT or CDCRT, so the contrast scan will be helpful. Another important issue is with the neck position. So I have seen in many centers they use a little bit of extended neck position. That helps in some ways, like keeps the normal structure away from the beam. When you are planning a conventional bilateral field, it sometimes helps some normal structures keep away from the beam. But if you are doing IMRT or image-based planning, it causes a real big problem. The problem is, like, if you want to fuse it with scan or MRI, or PET scan is in neutral position, so it will never match. The fusion will never be proper. So I prefer keeping the neck in neutral position so that I can fuse it with PET CT scan and MRI. Regarding mouth bites, many people use. Please.
Sayan, your time is already over. So if you
Oh, okay, sorry. I'll take only 3-4 minutes time. So mouth bite, the problem is that is actually sometimes what happens is it can cause irritation inside the mouth, it can add some uncertainties. Same thing is with the shoulder factor, which also causes uncomfort for the patient, and patient can move during the treatment. And when you are doing IMRT, if you can avoid this, you should avoid it. And if you think it is absolutely necessary, then only you use it. And during contouring, I will advise to contour some things which we sometimes miss, like the cochlea, the larynx, the distally aspiration associated swallowing structures, the lacrimal gland, the chiasm, and the optic structures, if we are treating the retrostyloid lymph nodes, and this should be contoured. And for the patient, there are some issues like the skin care and the dental care and the diet that I have already mentioned. For skin care, a collared shirt can cause irritation in the neck and cause mucositis, so better to wear a round neck or a V-neck. T-shirts, no tight clothes or undergarments with straps. In skin care, bathing or shower every day is good because it prevents infection with water not too hot, not too cold. A mild unscented soap can be used. To not rub the area and dye with a soft towel. You can use a moisturizer prescribed by the radiation oncologist and can use it twice a day. Should not shave and avoid direct sunlight on the area, and do not apply any cosmetic, deodorant or antiperspirant, makeup, perfumes, or powder in the treatment area. There should not be any scratching or injury. Regarding dental care, should brush twice a day with a soft toothpaste and toothbrush with fluoride, and the denture and processes should be cleaned properly, and mouth should be rinsed with 1 glass of water, 1 spoonful of baking soda and salt. That is the best thing to rinse the mouth. And so should take sips of water, coconut water, to keep the mouth wet, and they can use saline nasal spray to keep the inside the nose wet. They should give voice rate and should not whisper because it causes strain on the vocal cords. Lip moisturizer can be used but should not be used 4 hours before the radiation. These are mainly for the patients. I'll finish here. We should remember that we should treat the patient keeping the smile intact. So if you have any other comments or questions, please, I request you to ask your question or put your comments. Thank you.
Thank you, sir, for that brief and introduction on discussions about the role of radiotherapy and the cautions and precautions you have to take. Thank you. You have made it simple and easy for us to understand. Vikas, sir, should we take some question now?
Yeah, we can have some.
So if anybody who's having questions, starting from the surgeon to medical oncology to radiation regarding this oral cavity cancer, so please shoot it now.
There is one question in the chat box from Dr. Jyotiman to Dr. Sumit. Dr. Sumit, you are there? So any of the speaker can take it. What is the opinion and experience on weekly versus 3-weekly chemotherapy in the setting of definitive CTRT for locally advanced head and neck cancer in terms of patient compliance and oncological outcome? So what is your day-to-day practice and how to choose that whether to give weekly or 3-weekly? I think Prathamesh Pai sir can take up.
Yeah, I think because you are also trained and with us, and you know that the practice in TMH was weekly chemotherapy, and we had done a large randomized study which was 3-weekly versus weekly of cisplatin, and we found that the 3-weekly cisplatin was much better than the weekly. Of course, there were some issues with our doses for weekly, which was around 30 milligrams per meter square. But to our surprise, the issue that we always felt, that the patient tolerance, compliance, and completion of treatment was better than the 3-weekly as well. So it's not that our patients are weaker or they will not tolerate it. So we need to understand that 3-weekly chemotherapy with cisplatin concurrently is better than weekly. You have to select out your patients and you need to counsel them better. And of course, supportive care is of paramount importance.
I think that's the key. 3-weekly is better, and there is a randomized data also which is published. Any other questions?
So, Prathamesh Pai, sir, I have one question. Sir,
Yes, please.
Yes, sir. Actually, today only I got one patient with severe trismus, mouth opening almost zero. And CT scan, it shows there is massive destructions of right maxilla, and that tumor extend to the ITF, and a little bit of it, it was mentioned and showing in the CT scan touching the nasopharyngeal area. So how will we approach that type of patients? Zero mouth opening.
So as I mentioned earlier, there are two aspects to infratemporal fossa involvement. One is the clinical features and one is the radiological features. You need to actually select out your patients based on both. So you have got patients who have got involvement of the infratemporal fossa but have normal or slightly reduced mouth opening.
Yes,
The
sir.
ones that have severe trismus have usually more extensive disease and involvement of the skull base.
Yes.
So you need to look at those cases more vigilantly before you take them up for surgery, because you may not really benefit those patients. Again, we know that the patients who are having infratemporal fossa involvement and they are having skin involvement, bone involvement, perineural spread, and involvement of neck nodes, those are the ones that have the worst prognosis overall. So if you have to select out a patient who has trismus, but he has no neck nodes, very little skin involvement, very minimal bone involvement, those are the ones that will actually benefit, because you will actually give them a better mouth opening. Once you release all the fibrous elements of the muscles which are bringing the jaws together, you will not only clear the disease better, you will also be able to give a better quality of life. How do you do it? You need to address the fact that there is fibrosis. The muscles that hold the jaw together, temporalis and the lateral pterygoid, have to be released. So you need to go from lateral to medial. You need to go from superior to inferior. So release the upper jaw first. So that releases the pterygoid plate. And then when you go from lateral to medial, you will access the temporalis muscle as well as the lateral pterygoid attachment on the greater wing or sphenoid. So both these will be able to free that entire mass from the greater wing or sphenoid. So take the pterygoid plates and then take off the greater wing, the muscle attachment at the greater wing. So that would be my advice to you.
Sir, this patient, the only a little bit, just a few minutes more, I think it's already late. Just a little bit problem, sir. The tumor is almost a little bit touching the nasopharyngeal part. So what is the role of NACT in this one, sir? And assess again after, let's say, maybe 1 or 2 cycles. Does it have any role with NACT, sir?
So I would like to caution you on doing NACT haphazardly. Neoadjuvant chemotherapy suggests that you're going to follow it up with some definitive therapy. So first, you have to be very clear that what you're going to do with the patient. If the chemotherapy is going to be to see for response, and then you're going to offer them the patient palliation, this is not a right case selection. So you need to look at where is the disease. Is it operable to begin with? After the tumor shrinks, will you actually go ahead and remove the same parts? So remember that following chemotherapy, your margins don't shrink. You will remove the parts involved. So if you are not able to remove that area right now, it's very unlikely that you will be able to remove that following chemotherapy. Nasopharynx is not inoperable. So you need to look at where is the nasopharyngeal part of the disease.
Yes.
Is it coming on to the petrotemporal part? As I showed you, if you have got the lesion involving the oval, foramen ovale and posterior, those are not the cases, because you will come on to the internal carotid artery.
Yes.
So look at where is the disease involvement. Is it only in the eustachian tube area? Is it coming on to the foramen lacerum? If it is coming close to the foramen lacerum, this is not worth treating surgically.
Yes. Okay. Thank you. Thank you, sir. Vikas sir, anything else in this session?
Yeah, I think we'll end this session here. And I thank all the chairpersons and the speakers for today's session, Dr. Kudush Ahmed, Dr. Chinmiki Sayu, Dr. Prathamesh Pai, Dr. Sumit
you.
Goel, and Dr. Sayan Paul. Thank you very much, all of you, for joining the session. Thanks a lot. So we'll go ahead with our next session. Our next session will be on the colon cancer. I think our speakers are already here.
Thank you, Dr. Ahmed.
Thank you, sir.
Thank you, Dr. Pai. I think you give very good inputs on which cases to select and which not to go ahead with as far as surgery is concerned. Thank you very much.
Thank you, sir. Thank you.
So to conduct the next session, I will ask Dr. Farida to take over. Dr. Farida, are you there?
Yes, sir, I'm here.
Yeah, so just start the...
Okay, sir. Good evening, everyone. We will now begin the evening session by welcoming our chairperson. First, the chairperson is Dr. Nirpendra Tajam. He's a consultant radiation oncologist from Manipur. Second is Dr. V. Kammo. She's a consultant pathologist and principal investigator, PBCR registry in Nagaland. Then we'll welcome Dr. Ganesh Das. He's a senior consultant oncosurgeon, Arya Wellness Center, Guwahati. Then, sir, we'll go ahead with our first speaker, sir. Or will our chairmans would like
Dr.
to
Kammo can introduce. Madam, you are there?
Yeah, good evening, everybody. It's a pleasure to be with everyone. We will be starting a session on colon cancer. So I would Mark Krishnan from Cancer Institute Adyar to give us a talk on peritoneal cancer index and surgical approach in colon cancer.
I think Madam voice is not audible.
Oh, you
Madam,
see,
your
I
voice
don't
is not audible.
I in my place. Hello, can you hear me?
Yes.
Hello.
Yes, ma'am.
Yes,
Yeah,
ma'am.
Yes, ma'am.
Other people are also not able to hear. Ravindra, can you hear what Madam is saying? Farida?
Yes, sir, I can
Yes, sir,
hear
we can hear, sir. So we can hear.
Dr. Kammo, we
I
can hear
welcome
you.
Dr.
Please go on.
A.S. Ramakrishnan, yes, to start the topic on peritoneal cancer index and surgical approach in colon cancer. Can you hear me?
I can. I hope you can hear me too. Thank you very much for the introduction, and thanks to Dr. Vikas and all the organizers of this conference. With the permission of the organizers, I had made a small change in the topic of my lecture today because I thought that would be more useful for the surgical colleagues. And I will be talking on the incidental peritoneal metastasis in colorectal cancer. I hope you are able to see my slides.
Yes, sir.
Okay. So synchronous peritoneal metastasis occurs in around 5 to 7% of patients with colorectal cancer. And unfortunately, intraoperative diagnosis of a colorectal peritoneal metastasis occurs in at least 4% of patients who undergo regular surgery for colorectal cancer. And most often, the synchronous peritoneal metastasis is incidentally diagnosed during an exploratory procedure for the primary tumor. So what leads to the detection of peritoneal metastasis? We know that the accuracy of a CT scan in identifying peritoneal metastasis, especially those of low volume, is very poor. For instance, a peritoneal nodule that is less than 1 centimeter has a sensitivity of only 10 to 30% for detection by a CT scan. And it is also known that small bowel mesentery has a very poor sensitivity as far as CT goes, with only 10% of such nodules being detected on a CT scan. However, the good thing about incidental peritoneal metastasis is that they are always of a very low burden. The peritoneal cancer index, which I will tell you about, is quite low. It is only 3 to 5. And it is possible to completely remove these tumors in around 75 to 95% of patients. And because laparoscopy as a routine is not practiced before opening up a patient in colorectal cancer, unlike in gastric cancer, more than 50% of incidental synchronous peritoneal metastasis is actually detected during laparoscopy. Another reason is that a very few proportion of patients undergo laparoscopic colorectal surgery even nowadays. Sometimes even during emergency laparotomy, we might have come across situations where we detected incidental peritoneal metastasis for a patient with a colorectal cancer. So I'm sure you might be aware of this peritoneal cancer index, which is a scoring system for categorizing the extent of peritoneal metastasis. This was described initially by Dr. Sugar Baker. So basically, the abdomen is divided into 13 regions. Besides the 9 regions that is shown here, you have 4 regions in the bowel: the proximal jejunum, the distal jejunum, proximal ileum, and distal ileum. And you score the peritoneal metastasis based on the size on each of these regions and add up the total score. So the highest score that you can give is 39, and based on the extent of distribution in each quadrants, you can calculate the burden of peritoneal metastasis for that particular patient. Another thing that you must be aware of is the completeness of cytoreduction score. So this is based on how well you're able to completely remove the peritoneal metastasis. So if you leave behind no tumor, it is called a CC0. Whereas if you leave behind tumor more than 2.5 centimeters, it is CC3. So what will you do when you come across a patient, when you have opened up for surgery for colon or rectal cancer and you incidentally detect a peritoneal metastasis? You have a lot of options. You can just do a palliative procedure and then go on for palliative chemotherapy, or an immediate definitive procedure, that is primary tumor resection with CRS and HIPEC in the same setting, or an early definitive procedure where you just do a biopsy, or if needed a stoma or a bypass, and then after a few days either reopen the patient or refer the patient to another center for early CRS and HIPEC. CRS I mean cytoreductive surgery. Late definitive treatment, where you only resect the primary tumor at the time when you found the peritoneal metastasis, and then later refer for subsequent CRS and HIPEC. Or you have a delayed definitive treatment, where you do a biopsy, or if necessary a stoma or bypass, you give neoadjuvant chemotherapy, and then finally take up the patient for a definitive procedure. Or a 2-stage strategy, where you do a primary tumor resection along with cytoreduction, you give systemic chemotherapy, open up the patient a second time for HIPEC. So how do you decide what is best for you? It depends on whether the surgery is an emergency one or an elective one. Have you detected it at laparoscopy or after opening up the patient? Is the peritoneal metastasis as well as the primary tumor resectable? Do you believe in the concept of HIPEC? Are you experienced enough to perform a good quality CRS and HIPEC? Have you taken a consent for CRS and HIPEC before opening the patient? Do you believe in the concept of neoadjuvant chemotherapy in peritoneal metastasis? What is the financial status of the patient? Is there a referral center nearby where you can refer the patient for CRS and HIPEC? So you have to consider all these things. Palliative chemo in peritoneal metastasis has very poor outcomes. In spite of using even the latest targeted therapies, the median overall survival is just around 16 to 17 months, regardless of what chemotherapy you give. So this is not a very good option in a patient with a limited peritoneal metastasis. By limited peritoneal metastasis, I mean if the PCI score is less than 15, because more than 15 PCI score, cytoreductive surgery and HIPEC does not really improve the survival. So now coming to the immediate or early definitive treatment, where you either remove the tumor, do a CRS and HIPEC in the same sitting, or if you're not prepared for it, just take a biopsy and then reopen the patient or refer the patient at a little later date. So immediate CRS HIPEC, the advantages, it gets over in a single procedure, it's very cost effective, and there is no delay in starting adjuvant systemic therapy. Whereas you need to have taken prior consent, you should have the HIPEC machine ready, you should have a good coordination with your medical oncologist and anesthetist, and it is not usually recommended in an emergency setting. There is only one paper that has actually described the results of immediate CRS and HIPEC. Very small number of patients, around 17 patients, and the 5-year overall survival they have quoted was around 63%. Whereas immediate treatment with CRS alone is another option that is available. Again, this is a single stage definitive treatment. You could avoid the logistics and the potential morbidity that is associated with HIPEC. It is less costly because you're avoiding the charges of HIPEC. You still need expertise in CRS, And there is a controversy whether you should avoid HIPEC from a curative treatment strategy. Now, this was a paper from Japan that looked at immediate CRS without HIPEC, and they have quoted a median survival of 33 months. However, by avoiding HIPEC, what they reported was a 60% recurrence, and nearly 33% of these recurrence occurred in the peritoneal cavity. Now, the question comes whether HIPEC needs to be added to CRS or not. This is a very controversial area. To some extent, this controversy was even fueled more by the Prodigy 7 trial, which compared only cytoreductive surgery or cytoreductive surgery with HIPEC in patients with colorectal peritoneal metastasis. Unfortunately, this did not show a survival advantage of adding HIPEC over cytoreductive surgery. But the point to note in this trial is that even with only cytoreductive surgery, in patients with peritoneal metastasis, a median survival of nearly 41 months was achieved with good quality cytoreductive surgery. So this has established the role of cytoreductive surgery in the treatment of peritoneal metastasis. Now, there is some controversy about the results of this trial because this used a very short duration oxaliplatin in the HIPEC phase, which is no longer considered adequate strategy for patients undergoing HIPEC. What is the early definitive treatment? Where you don't do anything right then, just do a biopsy if necessary, a stroma or bypass, and then you can reopen the patient or refer the patient to another center. This gives you time to discuss with the patient, get consent and prepare the patient for the procedure, or gives you time to arrange to refer the patient to another center. There is no violation of surgical planes, and you can tide over an emergency situation. However, the patient has to undergo 2 surgeries, and there are associated financial implications. There may be some delay expected in starting the definitive treatment if you're going to refer the patient to another center, and subsequently there may be delay in starting systemic chemotherapy as well. So in case you do want to refer the patient to another center, what should you do? Do a thorough exploration of the abdominal cavity, and I've shown you the PCI scoring system. Describe the extent of peritoneal disease, preferably using this PCI scoring system. Take adequate biopsies of the peritoneal implants, and perform only the minimal surgery that is required to resolve the emergency situation, maybe just a stroma or a bypass. Do not perform tumor resection unless an emergency situation actually warrants resection of the tumor. For example, a perforated tumor. Now, what is late CRS HIPEC, where you just do remove the primary tumor and then subsequently you reopen the patient for CRS and HIPEC? Well, it gives at least some symptom relief and a psychological relief for the patient that yes, the tumor is out. It may satiate the ego of the surgeon that he has actually done something for the patient. But unfortunately, it delays the definitive treatment even more. Again, the patient has to undergo 2 surgeries with its financial implications. And doing a primary tumor resection makes the second surgery even more difficult. It becomes more extensive and complicated. There are more chances of permanent stoma, reoperation, and the surgical stress from the primary tumor resection might induce cancer growth. So this was a study from the Netherlands where they looked at patients who were referred to a tertiary center, a HIPEC center without resection or late referral after resecting the primary tumor. What they found is in patients who were referred late after resecting the primary tumor, in comparison to patients who were referred early without resecting the primary tumor, there was a delay in undergoing CRS and HIPEC, 93 days in the late referral group versus 37 days in the early referral. The late referral group had more extended bowel resections. Nearly 60% of the earlier anastomosis done during the primary surgery had to be resected, and 55% of these had malignancy on histopathological examination. That means the tumor has regrown by the time the patient was referred for CRS and HIPEC. There was a higher rate of relaparotomy after resection of previous anastomosis because of complications. There are more likely chance that the patient ends up with a permanent stoma, and it did not improve any survival by removing the primary tumor alone and then referring the patient. The other problem in removing the primary tumor and then referring the patient or reopening the patient at the second surgery for CRS HIPEC is that you lose the first line of defense. The intact peritoneal surface is considered as an excellent first line of defense for peritoneal carcinomatosis. If you dissect along the surgical planes, it creates a raw surface within which the tumor cells can get entrapped in fibrinous scar. Once the tumor cells are entrapped in the fibrinous scar, it is going to be difficult to resect these tumors, and the tumors become resistant to HIPEC. So major resection should be avoided in order to preserve this first line of defense, except in very symptomatic patients. If for some reason you are forced to do a tumor resection, then please do not perform wide resections that include the relevant lymph nodes. Just do a limited resection of the colon and including only the marginal vessels, but don't do a definitive lymph node resection, because this limited resection causes the definitive resection to be performed as part of the second HIPEC procedure and minimizes the problems that are associated with cancer cell entrapment in the retroperitoneal dissection. Now, what about delayed definitive treatment? That is by giving a neoadjuvant chemotherapy and then taking the patient later for one-stage CRS and HIPEC. Advantages of neoadjuvant chemotherapy, as you all know, it eradicates systemic micrometastasis, reduces the intraperitoneal tumor load, and probably it may lead to a less extensive surgery. You can assess the response and therefore select the patients who are going to be actually benefited from CRS and HIPEC. And this is more suitable if the primary is very large and unresectable. And it also keeps your medical oncology colleagues happy. But the problem is there is a slight possibility that disease progression may happen and what was initially a resectable tumor may become unresectable. Because of the toxicity of neoadjuvant chemotherapy, some patients may become ineligible for CRS and HIPEC. And giving neoadjuvant chemotherapy, you select chemo-resistant clones. So the disease that is left behind tends to be chemo-resistant. Therefore, the subsequent HIPEC may be ineffective. There is a phase 2 randomized trial from the Netherlands on systemic neoadjuvant chemotherapy called the Cairo 6. This is a phase 2, phase 3 study. The phase 2 part has been completed, and they have shown that it is safe to give neoadjuvant chemotherapy without much of disease progression. However, now they are conducting the phase 3 Cairo study, which will actually tell whether there is a benefit of giving neoadjuvant chemotherapy. Next is the two-stage approach. That is, at the primary setting, you remove the tumor, do a complete cytoreduction, then give chemotherapy, take up the patient at the end of chemotherapy for a second stage HIPEC. This again gives psychological relief for the patient. You're able to initiate systemic chemotherapy at an early date. But again, the patient is going to need a second surgery. There's a high chance of adhesions and more complicated surgery when you open up the patient for the second time. And there is no added oncological benefit. This is a paper published from France by Dominique Elias, who's a leading figure in the field of rectal surface malignancy. He looked at patients who underwent a single stage or one stage strategy or a two stage strategy. And they found that in the two stage strategy, the median interval between the initial cytoreductive surgery and the second surgery for HIPEC was 9 months. And by the time the patients underwent the second surgery for HIPEC, 86% of the patients had peritoneal recurrence. And around the 28, nearly a third of the patients had a high PCA score more than 10. And the two-stage strategy did not really improve the survival. I just have 2-3 more slides. I will complete very soon. Let's skip this slide. So finally, coming to our initial options that we had in front of us. Palliative treatment in a patient with limited resectable peritoneal metastasis should be avoided because these are patients who are likely to benefit from definitive treatment. So that is not an option to be considered. You could consider immediate or early definitive treatment based on how well you are prepared to do CRS and HIPEC at the initial setting itself. If you're not very well prepared, it is best to do a biopsy and then prepare yourself, prepare the patient, and then either reopen the patient or refer the patient to another center for CRS with or without HIPEC. The next option of a late definitive, as I told you, resecting only the primary tumor and then reopening a second time should not be done because you're violating the surgical planes. You're making the second surgery much more difficult. So that option, please do not consider. You could consider a delayed definitive treatment by giving neoadjuvant chemotherapy and then taking up the patient for CRS with or without active. The two-stage strategy, as I showed you in the last slide, is again not a very ideal option. Well, if you consider that HIPEC is not going to be of any use, well, you could do a primary tumor resection with CRS alone, but then don't open up the patient a second time for performing only HIPEC. So now we have seen how to deal with peritoneal metastasis. This is my last slide. It is more important to avoid an incidental detection of peritoneal metastasis. So you need to know which are the high-risk patients who have a higher risk for developing synchronous peritoneal metastasis. Young patients with a T4 disease on the CT scan, node positive, right-sided mucinous tumors, poorly differentiated tumors, or wherever you have a CT suspicion. In these patients, please electively plan a laparoscopy before you open up the patient, because these are patients with a more than 30% chance of finding peritoneal metastasis. So you can avoid an incidental detection of peritoneal metastasis. You can diagnose peritoneal metastasis and be prepared to deal with it. Thank you.
Thank you, sir. Sir, now I would like to ask Dr. Nirpendra Tamjam to kindly introduce our next speaker. Sir? Sir Nirpendra?
Hello.
Yes.
Good evening. I would like to call upon the next speaker, Dr. Kunjahari Midhi. He will be talking on the adjuvant treatment in colon cancer. He is the Director of Oncology and Senior Consultant in Head of Medical Oncology and Hemato-Oncology in Bhatra Hospital Medical Research Center, New Delhi. Can you please take over, Dr. Kunjahari Midhi?
Yeah, good evening, everyone. Yeah. At the outset, I thank organizer for giving me the opportunity to speak on the topic, especially Dr. Vikas. Sorry. So in next 15 minutes or so, am I audible?
Yes, yes.
Yeah. In next 15 minutes or so, I will be discussing briefly about the role of adjuvant chemotherapy in colorectal cancer.
Sir, you have unmute yourself, sir. Sir, can you unmute yourself?
Yeah. When we discuss colon cancer, we should also discuss along with that the rectal cancer, because colorectal cancer is discussed together. So since my topic is on colon cancer, but briefly I will touch upon rectal cancer adjuvant treatment also. Although we have discussed yesterday in detail about the rectal cancer, the points I will be discussing about the indication of adjuvant chemotherapy in colon cancer. That means what are the indication for chemotherapy, which stages needs chemotherapy, then the chemotherapy regimens, then the duration of treatment, whether 6 months versus 3 months, and is there any difference in elderly patients, and adjuvant treatment in rectal cancer. Subsequently, last but not the least, will be the take-home messages.
Dr. Kunjari, your slides are not moving.
Probably.
Yeah, so you just don't put on the slide mode. Just continue with the normal.
Slide to move or screen.
Ravindra, you have the presentation?
Yes. Right. It slide to move
Don't put on the slideshow. Just
slideshow to
I think there is an issue from that
Yeah,
side.
yeah, yeah.
Yeah, now it's
Okay, yeah. So we all know how do we manage the colon cancer. So for colon, after the initial staging, there is a multidisciplinary team discussion. Then we'll decide for surgery. Then subsequently, wherever indicated, we need to give the chemotherapy. So we all know the staging of colon cancer, but I will be stick to stage 2 and stage 3 colon cancer, because stage 3 definitely needs chemotherapy, but in stage 2, in some cases which are high risk, those cases needs the chemotherapy. So what are the chemotherapy armamentarium available in colorectal cancer? We have the 5-FU, and leucovorin combination, then capecitabine, that is capox, then folfox. All these are chemotherapy regimen. So who should receive adjuvant chemotherapy in colon cancer? Stage 1 cases do not require chemotherapy. Stage 4, there is no question of adjuvant chemotherapy, but stage 3 is the definite indication of adjuvant chemotherapy. And what about stage 2? In stage 2, when it is high risk, those patients needs the chemotherapy. So adjuvant treatment is recommended in stage 3 cases, all stage 3 and high risk stage 2 patients. The patients with stage 2 are high risk if they present at least one of the following characteristics. These are less than 12 lymph node sampling, that is suboptimal lymph node sampling, poorly differentiated tumor, vascular or lymphatic or perineural invasion, tumor presentation with obstruction or tumor perforation, and pathological T4 disease. These are the high risk factors for stage 2 colon cancer which needs chemotherapy. The value of adjuvant chemotherapy for patients with stage 2 disease is controversial. When determining the benefit of adjuvant chemotherapy in this group of patients, several factors should be taken into consideration, including number of lymph nodes analyzed after surgery, the prognostic features, anticipated life expectancy, and comorbid conditions. In stage 3, there is definite benefit of addition of adjuvant chemotherapy. The p-value is significant. And in stage 2, this is not highly significant, but there is some benefit of addition of chemotherapy. So adjuvant chemotherapy is indicated for stage 3 colon cancer, which are lymph node positive, either folfox or capox, capecitabine or infusional 5-FU leucovorin as an option for some patients, folfox or capox for patients less than 70 years age, and use of this chemotherapy in more than 70 years should be with caution and after consideration of all the comorbidity and the general condition of the patient. Antibodies, these are which are that anti-EGFR antibody or anti-VEGF antibodies are not indicated in adjuvant setting. This is clear by now. The decision for adjuvant treatment should balance the risk of cancer mortality and that of comorbidities. The specific problems are seen in stage 2 cancer, elderly patients, and the role of biological markers we have discussed. There is no role of there is lesser role of biological marker, except the MSI and MSS. So in stage 3 colon cancer, lymph node positive disease, initial study was with 5-FU and levamisole, and the benefit was 10%. So this was significant. The exact trial, which reveals the overall survival benefit in stage 3 colon cancer with addition of adjuvant chemotherapy. So folfox is the standard of care in adjuvant setting in stage 3 colon cancer. This is established. So what are the regimen or chemotherapy option beyond 5-FU in the adjuvant setting? These are several trials, and from this trial, it has been established that the role of oxaliplatin, role of capecitabine, and the combination of capecitabine and oxaliplatin, that is capox, and these are already established. So oxaliplatin based adjuvant chemotherapy for stage 3 colon cancer, it has been seen that 6 months of FOLFOX was associated with 7.5% absolute reduction in the risk of recurrence and 4.2% reduction in the risk of death. Subsequently, there was an discussion and analysis about the duration of chemotherapy, whether 6 months or 3 months. So to discuss about the duration of chemotherapy, ideal duration of chemotherapy, that is the 6 month oxaliplatin associated with several cumulative adverse events. On the basis of the cumulative adverse events, the IDEA collaboration for evaluation of duration of oxaliplatin based adjuvant chemotherapy came out. And in elderly patients considered to receive fluoropyrimidine alone to lower, but that may lower the benefit of chemotherapy without addition of oxaliplatin. It has been came out from the mosaic study that FOLFOX4 in comparison with leucovorin and 5-FU infusion, the benefit of FOLFOX4 was established. Even in stage 2 colon cancer, the benefit of addition of chemotherapy, adjuvant chemotherapy was seen, but this was not highly significant, as it was in stage 3, it was significant. Now, whether FOLFOX better or Xelox is sufficient. So FOLFOX or Xelox, that is oxaliplatin based chemotherapy with capecitabine or infusional 5-FU leucovorin. This was studied in Xeloxa trial. This was a phase 3 trial of Xelox, that is capecitabine plus oxaliplatin versus 5-FU leucovorin, that is without oxaliplatin, only infusional 5-FU leucovorin. And it was found that Xelox is a valid option. And in overall survival and in disease-free survival also, Xelox was better than 5-FU leucovorin. And 5-FU leucovorin was also compared with the FOLFOX, and finally it revealed that FOLFOX is better than 5-FU leucovorin. Now, whether 3 months versus 6 months. So this was the international duration evaluation of adjuvant chemotherapy, that is IDEA collaboration study. And this was a study of more than 12,000 of patients, and approximately 60% were treated with FOLFOX and 40% treated with CAPOX. So the study overview was 3 months of FOLFOX or CAPOX and compared with the 6 months of FOLFOX or CAPOX. This was a non-inferiority study design. So final outcome, the statistical non-inferiority of 3 months of compared with 6 months of adjuvant therapy, and that was not established for the whole study population. So 3 months of therapy was not significantly non-inferior to 6 months of therapy for patients receiving CAPOX. 6 months of therapy was significantly improved compared with those receiving 3 months of therapy for patients receiving FOLFOX. Very importantly, 6 months of therapy showed superior disease-free survival compared with 3 months of therapy for patients deemed to have high risk, that is T4 or N2 tumors. So it is established that 6 months of therapy is a standard treatment, and it is better when there is high risk factors are there, especially T4 or N2 tumors. In overall survival also, 3 months versus 6 months comparison, finally it was concluded that in high risk, when there is high risk factors, high risk tumor is there, that is T4 or N3 disease is there. So in this N2 disease is there. So in this case, in this type of cases, 6 months of FOLFOX, 6 months of therapy is the standard, but without high risk factor, 3 months of CAPOX may be equally better, equally good option. So now we have discussed that 3 months of CAPOX and 6 months of CAPOX or FOLFOX when it was compared. So in low risk disease, 3 months of therapy we can give very well, and in high risk disease, 6 months of therapy is needed. So at least we can reduce the duration of treatment. So in this trial, they have added the tumor deposit criteria also. If tumor deposit criteria is also considered along with the lymph nodal metastasis, so this is better to define the duration of adjuvant therapy. That means when there is tumor deposit present after the surgery, the high number of tumor deposit present, so that is also indication of high risk disease, and that needs longer duration of chemotherapy. So from the IDEA collaboration, the key takeaways were, this is the acceptable to offer 3 months of CAPOX for patients with stage T1 to 3 N1 colon cancer. Patients with T4 or N2 disease should be considered for 6 months oxaliplatin based therapy or 3 months of CAPOX if a minimal loss of benefit in disease-free survival or overall survival is agreeable. Tumor deposits have demonstrated use as a robust prognostic factor and their influence in determining the duration of adjuvant therapy. 3 months of adjuvant chemotherapy for patients with stage 3 colon cancer dramatically decreases the risk of neurotoxicities without compromising overall efficacy. So it is established that duration of treatment, if we see from the toxicity ground, neurological toxicity 2 times to 6 times lower, diarrhea 20% to 30% lower, mucositis 2 times lower, and hand-foot syndrome 2 times to 3 times lower. From the economic point, if we see, we can significantly reduce the economic burden of using 6 months of CAPOX chemotherapy. If we use 3 months of chemotherapy, the cost cutting, the economic benefit is significant.
Dr. Melissa?
Yeah. In stage 2 disease, again with high risk factor, chemotherapy is beneficial, and the same chemotherapy, same criteria, same chemotherapy regimen are used. So decision to give chemotherapy based on the clinical pathological markers of high risk and molecular biomarker. And is there any difference in elderly? If we consider the ECOG performance status and comorbidity and all the demographic parameters, everything, so for standard age and elderly age, that means the younger age and the elderly, the chemotherapy regimen and chemotherapy indication, all the parameters are equal. Only we have to see the comorbidity and the patient's condition. So only on the basis of age, we should not refuse the chemotherapy or we should not modify the chemotherapy regimen. Finally, only one slide for the rectal cancer adjuvant treatment. When total neoadjuvant therapy is given in rectal cancer in neoadjuvant setting, that is chemoradiotherapy, then in that case, when surgery is done and after surgery, if pathological complete response is seen, then in those group of patients, we can avoid the adjuvant chemotherapy. But if pathological stage after surgery is stage 2 or stage 3 in resected rectal cancer, then adjuvant chemotherapy for chemotherapy with FOLFOX or CAPOX is indicated to increase the disease-free survival. Yeah, this was the slide. So chemoradiotherapy with capecitabine, week 1 to week 6, then surgery at 12 weeks, then adjuvant chemotherapy is optional. And if short course radiotherapy is given and neoadjuvant chemotherapy is given from week 3 to week 16, if surgery is done at week 24 to week 28, if there is pathological complete response, then we can avoid the adjuvant chemotherapy. But if there is residual disease or of either stage 2 or stage 3 stage, so that group of patient needs chemotherapy in adjuvant setting. So what we have discussed, adjuvant fluoropyrimidine based chemotherapy improves survival in stage 3 and high risk stage 2 colorectal cancer. Choice of chemotherapy regimen and duration of treatment should take into account the magnitude of benefit and the associated toxicity. 3 months of adjuvant chemotherapy is enough for patients who are low risk, that is T1 to 3 and N1, while patients who are high risk, that is T4 or N2, may need 6 months of treatment. Thank you.
Thank you so much, sir. Now I would like to request again Dr. Nirpendra, sir, to kindly introduce our next speaker. Nirpendra, sir, are you there?
I think Farida, you can go ahead.
Yeah, okay. Again, then I would like to introduce our next speaker, Sir Dr. Ullas Batra, sir. He is a senior medical oncologist from Rajiv Gandhi Cancer Institute, Delhi. He will be talking on metastatic colon cancer, decision making with various mutations. Dr. Ullas Batra, sir. Yeah.
Okay, thank you. First of all, thank you for the invite and lovely to have been here. Last time also the conference was very interactive and really liked coming and speaking over here. In fact, I would like it more when we have hopefully the next conference in a physical way and the non-virtual way, because coming out of Delhi and having the fresh air of Northeast is much better. So if nothing for science, I think for fresh air, all Delhiites would like to come to Northeast actually. So I have been asked to speak. Come again?
Now the air is filled with COVID. That's why.
Next year maybe. Oh, it's better than in Delhi. Okay, so I had been asked to give a topic about metastatic colon cancers, decision making with various mutations. And my first reactions when I heard the topic was, there is something missing over here. I didn't realize what was missing in that. And then I looked further. I thought there should be something called as the left and the right side also, which has to be missing over there. And my further reaction then with Dr. Vikas is, without his permission, I've changed the topic slightly, which is saying metastatic colon cancer, disease making with various mutations and the sidedness of colon cancer. And I will show you why I have written that extra thing over there. And to me, this is the topic which basically makes perfect sense right now. So it was very easy to treat colorectal cancer in 1995 when I joined my MBBS. That was almost, you give them 5-FU leucovorin, you had various regimens, you had the Roswell Park regimen, you had the D-Garamond regimen, and things were very, very simple. Things became a bit better when I was doing my DM, when you had oxaliplatin, ionotican, oral 5-FU pyrimidines. Things are much more better right now when you have cetuximab, panitumumab, bevacizumab, aflibercept, Pembro, Evo, AP, Nivo. So a lot of good things have come over there, and which has basically led to a survival from at least 3 to 4 months without treatment to approximately 36 to 38 months of treatment in a very select group of patients actually. So how do you decide? How do you decide which agent to use? Whether you listen to your heart and you use or the medical representatives which come over there, or you look at the evidence-based data. So my job here is to show you the evidence in the next 10 minutes about which mutations to use in which sidedness, and then take it forward from there. If there are any residents listening over here, this is what was called as the Ikigai. This is the book that I am reading, which is a Japanese secret to a long and happy life. And this basically shows the Ikigai is the center, the happiness. And then you should think about what you love, what you are good at, what you are paid for, and what the world needs. I have modified this a bit. So let us say what our colon cancer patients want for a happy life. So if the patient is the center of the thing, what he basically wants is the patient clinical factors. The treatment should depend upon that. It should depend on the patient's preferences. It should depend upon the tumor clinical factors. It should depend upon the molecular profile, and molecular profile and the clinical factors are what I'm going to speak about in the next some time. So you have the patient clinical characteristics, you have performance status, you have comorbids, you have prior adjuvant treatment. If somebody has just taken a FOLFOX 6 months back and then has a neuropathy, you will obviously not want to give them FOLFOX once again. If somebody has got a allergic reaction to cetuximab, you will obviously not really want to give a MAP once again. If the patient has got hypertension, thrombosis, the VEGF inhibitors actually come down the line. Patient's preferences, the expectation of the patient, what's the toxicity profile is very, very important. The tumor characteristics like the tumor burden, resectability, aggressiveness, and other symptoms are very, very important. And the most important over here is one on your left side, which is the RAS, RAF, and the MSI pattern. So that's what basically we are going to look at in the next some slides. So if the people are still awake and not really slept in the for the next 10 minutes, I would like to show you. Now, I have divided this rectangle you are going to see much more often. You have right hemicolon, you have left hemicolon. You have RAS wild type, you have RAS mutant. Okay. You further subdivide the RAS wild type into the BRAF mutant. You also have MSI-H, which can encompass both the RAS wild type and the RAS mutant. You then have a specific RAS mutants, which is the KRAS 12C. And in the RAS wild type, you have the anti-HER2. So again, you have the left side, you have the right side, you have the RAS wild type, you have the RAS mutant, you have MSI-H, which can extend for both RAS wild and mutant. You have BRAF mutation and HER2 new mutation in the RAS wild type. You have specific RAS mutations in the which we can see about later. So under these circumstances, I will let you know which therapy is best for which subgroup. So let's start with the first one, the left hemicolon and the KRAS wild type. So we now know. So just listen to me. We are doing left-sided RAS wild type. Now, this is cetuximab or panitumumab, that is the anti-EGFR maps are the ones which have got the broadest evidence versus only chemotherapy. So there were two trials. One was the Crystal trial, one was the Taylor trial, which basically showed that you have an advantage of around 7 months, 3 to 7 months, if you use an anti-EGFR. Now, what happens if you compare these with the bevacizumab? So anti-EGFR plus chemotherapy is better than only chemotherapy. Now, this was the two trials, the FIRE trial and the CALGB trial. Again, if you have a left-sided tumor, then your median OS is much better with if you use the anti-EGFR map first and the VEGF about that later. So the FIRE trial and the CALGB trial showed that if you have a left-sided tumor, which is KRAS wild type, definitely your anti-EGFR is much more important. And this was a meta-analysis of all the 5 studies, which again basically showed that all these trials favored anti-EGFR left-sided KRAS wild type. So this is again the OS. This is also a trial of the 10 trials, which has basically shown that if you have KRAS wild type, if you have a left-sided tumor, anti-EGFR plus chemotherapy is the way to go. So I have put across over here. You see, this is left hemicolon. This is RAS wild type. If you have this, you please use CT doublet plus anti-EGFR. With CT doublet, doesn't really make a difference. It's normal choice. Some people use FOLFIRI, some people use FOLFOX. Doesn't really make a difference. There is slightly more data of FOLFIRI with anti-EGFR. Fair enough. So that is left-sided hemicolon, RAS side, KRAS wild type. Now, let's look at the right-sided colon and pan-RAS wild type. Now, very important, and there is where, you know, the personalized medicine, the thing comes up over there. If you have a right-side colorectal cancer, your anti-VEGF agents are much more better than your anti-EGFR agent. So if you have a right-sided tumor, even with a RAS mutant or a RAS wild type, you should use a CT doublet or triplet plus bevacizumab. So RAS wild type, left side, you use Erbitux. RAS wild type, right side, you use bevacizumab. Very, very important. Does that mean that there is no role of giving cetuximab in the RAS wild type and the right side? No, it is not. If you actually want more response, if you really want that the patient's tumor, so you have a liver which is shuttered, you have lung which is shuttered, you want response, then probably in those patients the response is higher if you use anti-EGFR plus chemotherapy, and the response rates are basically better. So if you want a response, probably then an anti-EGFR is much more better in the right-sided wild type also. So again, RAS wild type, left side, anti-EGFR. You want response in the right side, do anti-EGFR. If you don't want a response, probably at that time, bevacizumab is very, very important. Now let's look at, this was about the RAS. Now let's look at about the BRAF mutation. Now we very well know that BRAF mutation is something which comes basically over here. So it's almost like saying, if I am competing in an exam, if let's say I always say Senthil or Sahu or everybody else is there, most of the time this is where I stand. That is, I stand at the bottom of this. So BRAF V600E mutation is an absolutely poor prognostic and a predictive factor to anti-EGFR. So if you have a pan-RAS wild type, please look for BRAF. If you have a BRAF mutant, do not use cetuximab only. So what do you use? Then again you use Folfox or Folfiri plus a anti-VEGF agent. So again, very, very important. You look over here that if you have a BRAF mutation, even in presence of a KRAS wild type, irrespective of your side, right or left, please use bevacizumab plus a chemotherapy doublet. Which chemotherapy, doublet or triplet, doesn't really make a difference. Now, so that was about the mutants. Now let's look at the MSI status. So if you, so what's new on the horizon for BRAF mutant? You have a drug called as, which is a BRAF V600 inhibitor, which is encorafenib, binimetinib, and cetuximab. A beautiful waterfall curve, and I'm sure this drug basically got the FDA approval for usage, but this drug is at present not available in India, so we really can't use it. So either you use a Folfox, Folfiri plus Bev, or you use a triplet with a anti-V6 inhibitor. So if you have an MSIH, and there was a question in chat box that should we be testing for MSI, and you should definitely be testing for MSI, because in stage 2, it can tell you whether chemotherapy is needed or not there. In stage 4, it can actually tell you about immunotherapy. And this was the Keynote 177 trial, and look at the difference in the survival between the green and the I don't know what color is this, and the dark red. The difference is huge. And this basically shows that if you have an MSIH in the first line setting, you should definitely use immunotherapy. The one bad thing about this, I will just show you, is that probably the green one, there's a people which actually fall down initially. There are certain people who do not respond initially. So if you have a very high disease burden, I would request you to probably start with chemotherapy and then give immunotherapy. Otherwise, immunotherapy in an MSIH people is an absolutely fantastic thing. It's not only about pembrolizumab, you have Pembro, you have Nivo, you have Nivo plus EP. And definitely, if you have an MSIH, you can actually use the anti-PD-L1 tumor actually. So I hope left-sided, right-sided, CG doublet, and MSIH is basically clear. So just when you thought that this is all getting over, and I'm going to rid you of the torture that I'm telling you, there is something more to come over there. So these are not the only mutations. HER2 new is coming up in a big way over there. Now, HER2 new applications basically occurs in 5% of colorectal cancer patients, and they are a predictor of an probably a loss of response to anti-EGFR. So not sure that whether you test for anti-EGFR and HER2 upfront, but if you have a HER2 new, you probably will know that there is the anti-EGFR therapy is not really going to expand. And the very important thing, which is NCCN guidelines, which basically says is that anti-HER2 therapy is only indicated in HER2 amplified, not mutation amplified tumors that are also RAS and BRAF wild type. So if you have a double pan-RAS and BRAF wild type, check for HER2. If you have a HER2 new mutation amplification, probably you are not really going to respond to anti-EGFR therapy as good. So if you are not really going to respond to anti-EGFR, what are you going to respond to? You may respond to trastuzumab and lapatinib. You may respond to trastuzumab and pertuzumab, but these are experimental. We need more data out of it. What we know is that HER2/neu is a resistance pathway. It is also a way that maybe your anti-EGFR therapy won't really act on this. We spoke about HER2/neu. Now let's look at the specific mutations. I mean, everybody knows that I do lung for my research purposes. So the KRAS 12C can be seen in lung. KRAS 12C specific mutation can be seen in colon. But there's a difference in the way sotorasib will behave in colon vis-a-vis the way it will behave in lung. So if you look over here, the objective response rate in NSCLC with sotorasib is 32.2%. It is only 7% with in the colon cancer. The disease control rate also is slightly lesser with sotorasib and more in the colon cancers. So if you look at the specific RAS mutation, it is not ready for prime time. Anti-HER2, not ready for prime time, but I'm sure in the next 1 year or so, we are going to get anti-HER2 therapy more often than not. If you again thought the picture was getting over, there is not. You can have even more mutations. We are from the national capital of India and the national pollution capital. For national pollution capital, I can't do anything, but for the national capital, we do NGS. But we need to remember that, ALK, ROS, and NTRK, they do occur in the elderly people, right-sided tumor, node spreading. Again, very, very few, less than 1% of patients. But if you have a patient who can afford, there is no harm in doing an NGS also. And the NTRK fusions also have rather poor results in metastatic CRC. So to conclude, there has been a paradigm shift in the management of colon cancers. Molecular analysis and the sidedness play a decisive role. Liquid biopsy is coming up in a big way. Left-sided colon, pan-RAS wild type, anti-EGFR, right-sided chemo. Look for KRAS mutation, look for BRAF mutation, look for HER2/neu also, and maybe treat it. And this is my last slide. I think personalized treatment in colon cancer is very important to avoid both over and under treatment and getting the treatment right. So with this, thank you. My time is up, and I really hope I made some sense. Thank you.
Thank you so much, sir. Vikas, sir, can we have time for some questions?
Yeah, I think the chairperson can ask any questions.
Thank you so much for Dr. Patra for your very elaborate lecture. And I'm very sorry because I'm having a very bad power fluctuation. So I'm very sorry. Just now the light came and I could put on, but it was a very good lecture. Thank you so much for your this thing. Now I think we will be having the question hours after this, because.
Yeah, so there is some question in the chat box, Dr. Ullas Batra. Is it the surgical risk is more after the use of bevacizumab? Like some surgeons, doctor saying that they are not comfortable to do a major liver resection after bevacizumab. So what's your take?
So yeah, I mean, absolutely right. See, it again depends on why are we postponing the initial surgery? Do we want a response or not? So bevacizumab plus the chemotherapy has never really led to a great response. But if my surgeon feels that they want a more response, I'll be happy to add cetuximab or panitumumab. Having said that, there is no overall survival advantage in adding a biological therapy to chemotherapy in a potentially operable patient. So if you have a liver limited disease, if you think your chemotherapy is going to do the work, fantastic. Bevacizumab won't really do because they will not be very comfortable. If you want a response, if you really want that the tumor was 7 centimeter, you want to shrink it to 4 centimeter, I would like to give you 4 cycles of cetuximab or panitumumab along with chemotherapy, and then probably get the patient to the table, stop cetuximab after that, give only chemotherapy, and then go ahead.
Yeah, I think that also answers Dr. Gaurav Das' question. Where the surgeon is keen on curative surgery, which agent should be the better thing?
So I will not add biological over there. If my surgeon wants a response, my chemotherapy is good enough. If it doesn't work, I'll give cetuximab or panitumumab. But bevacizumab has never really shown to have a increase in the response rates. And the problem is the surgeons will not be able to do surgery for 6 weeks after that. So no, Bev, definitely.
Nipen, any questions from your side?
Is there any questions from the audience?
No more questions.
Okay.
Other questions, I think Dr. Ramakrishnan has already addressed in the chat box. So thank you, sir, for your quick responses. And Farida, over to you.
Yes, sir. Thank you so much for this wonderful evening session. Now, I think we'll go ahead with the next panel discussion.
So thank you all the chairpersons, Dr. Khamo, Dr. Nipen, and thanks to all our speakers, Dr. Ramakrishnan, Dr. Kunjari Medhi, Dr. Kunjari Medhi's son also for helping for preparation, getting the slides on time, and Dr. Ullas Batra as always. Thank you so much. Thanks. We'll try to get a physical conference next time as suggested by the speakers. We'll try it definitely. So
the Delhiites are in need of fresh air. We do need a conference in Northeast.
We will try, sir, definitely.
Yeah. Thank you. Thank you.
So moving on to the next session. Next session, we have a panel discussion. Thanks to Dr. Farida. Dr. Farida is a radiation oncologist working in Civil Hospital Shillong. Thanks, Farida, for the conducting of this session.
Thank you, sir.
So our next session is a panel discussion. For the panel discussion, I would like to invite Dr. Ritesh Tapkire. Dr. Ritesh Tapkire will be moderating the session on early lung cancer. Dr. Ritesh is the head at Department of Surgical Oncology at Kachar Cancer Hospital and Research Institute in Kachar, Assam. And for the panelist, I'll be like to invite Dr. Bijay Saikia sir, who is the ex-professor and the head in the Department of Medical Oncology, Bhuyan Cancer Institute, Guwahati, currently working as a consultant medical oncologist at Guwahati. Dr. Ashish Rai, he is a consultant radiation oncologist and head in the Department of Radiation at STNM Hospital, Sikkim. Dr. Niju Peku, who is a MCS surgical oncologist at Health City, Guwahati. Dr. Indibor Singh sir, who is a professor in the Department of Radiation Oncology at RIMS Imphal. He was also the ex-head of the department in RIMS Imphal. Dr. Farida Momin, who is a consultant radiation oncologist at Civil Hospital Shillong. Dr. Sandip Taparia, our favorite nuclear medicine specialist from Northeast. Dr. Pratap Kakoti, who is a consultant oncoradiologist at Guwahati. Dr. Bihari Agarwal, who is a consultant surgical oncologist working at Jorhat, Assam. Dr. Anupam Sharma, he is a professor in the Department of Pathology at Bhuyan Cancer Institute, Guwahati. Dr. Vijay Nongpure, who is the assistant professor in the TB and respiratory diseases department at NIGRIMS Shillong. And at the end, Dr. Donbok Lang Linser, who is assistant professor in the Department of Radiology at NIGRIMS Shillong. So I think Dr. Ritesh has already joined. Over to you, Dr. Ritesh. Thanks.
Yeah, good evening, everyone. My slides are visible?
Yes, you can see that.
Okay. So thank you for this opportunity. Without wasting much time, I'll go to the start the panel discussion. So we have elite panelists, including radiation, medical, surgical oncologists. We have radiologists, pathologists, nuclear medicine specialists to complete the panel. And we have a pulmonologist also, fortunately. So this is a 55-year-old gentleman, smoker in the past, presented with history of cough of 3 months duration without any comorbid illness. So can I have some comment from Dr. Pratap Kakoti and then from Dr. Vijay?
Yeah. Can you hear me?
Yes, Dr.
Yes.
Pratap.
Yeah. There is a lesion, soft tissue lesion in the right upper lobe, abutting the pleural surface. The margin is relatively irregular. So there is solitary lesion is there in the right lung. He's the smoker, 55 years. So this, because of his irregular margin and this high risk patient, I think you should think of a carcinoma.
Yes, yes. So,
yeah.
So my next question is to Dr. Vijay. How often do you get lesions like this? Because you must be seeing a lot of patients who are coming with pulmonary tuberculosis also. So how often do you find it to be benign?
Yes, good evening, sir. Can you hear me?
Yes.
Yes.
Yeah, hi, good evening, everyone. So yeah, solitary pulmonary nodule in the lung. that is fairly common. We see a lot, but most of the time, another thing that we look at, probably Dr. Dunbar can also elaborate on the CT findings, is we look at calcification here on this. This is not the ideal window to look for calcification. It's on the lung window, but usually if we see a lot of calcification, especially in the Northeast, we would think of probably a granuloma, probably a post-infective granuloma, because tuberculosis is again a very big differential diagnosis, especially here in the Northeast, where tuberculosis is quite endemic and rampant. But looking at that image, probably that doesn't look like, even though it's not in the correct window, probably it doesn't look like there is much of calcification. So definitely would warrant, it looks highly suspicious. So we would warrant for further investigation for such kind of lesions.
So my next question is to Dr. Dong Bolong. Suppose if we have a solitary pulmonary nodule in a new patient, so what would be the criteria to call it as benign or malignant?
Good evening, sir. So, like Dr. Vijay has pointed out, in this case, where we see the nodule, ideally, if we would have seen this nodule in a medicinal window, that would have added to our diagnosis. So to call it whether it's benign or malignant, first we will be seeing at the internal morphology of the internal contents of the nodule. If, like Dr. Vijay said, if there's calcification, whether the calcifications are dense, they are popcorn calcifications, then or laminated, these are for the benign calcifications. But if the calcifications are stippled or calcifications, these may be for the malignant. And we also see for the fat content inside the nodule. Suppose there's a fat content, that when we can think of hematoma. Apart from that, for the malignant lesions, then we have to see for the nodule, margins of the nodule, like we say here, it's a bit irregular. Is it spiculated or lobulated margins? This will favor malignant lesions. And also the size of the lesion. If the size is larger, the nodule size is larger, that will favor malignant more than benign. So these are few points.
Yeah, so to summarize, size, size of the nodule, density of the nodule, these are important things to consider when we are evaluating a solitary pulmonary nodule, other than the relevant history of the patient, especially the history of exposure to asbestos or uranium radon or smoking history.
Yes.
More important.
Yes.
Yeah. And nowadays there is a CT software volumetric analysis also. The most important thing is, if we have a previous imaging available of the same patient, then it is good to just compare the pulmonary nodule with the previous imaging, because that is the most important criteria.
Yes, we can compare. If the size is growing very fast, then we favor a benign lesion, and if it's growing very slow, then that also may favor a benign.
So
anything
can you just comment on the tumor doubling time of most of the lung
so
cancer?
Most of the benign doubling time will be less than 1 month, and most of and more than 18 months. So anything in between are more in favor of the malignant.
Yeah, so generally speaking, if the tumor doubling time is more than 500 days, we can with 98% probability we can say that it is a benign nodule. Yes. So so these are the recommendations from Fleschner Society. Most of these recommendations are based on the data from the Western world. So in India, there might be, we may have to take some other decisions, especially because granulomatous diseases are more common in India. So these are the recommendations of follow-up for a solitary pulmonary nodule. So we will just skip these things. And now, this is a question to surgical oncologist, Dr. Niju or Dr. Bihari. One of them can take. How do we approach this patient?
Hello.
Dr.
Hello. Hello, sir.
Yeah, go ahead. You are audible.
Awesome. Should I take Bihari, sir?
Yeah, Niju, you take up.
Yeah.
Okay.
Go ahead.
As for these patients, as CT scan is already done, so next things I would I will advise metastatic workup, as it looks like resectable. So for metastatic workup, PET scan and also bronchoscopy. And also,
do you want to do you want to establish the diagnosis first, or do you want to do the PET CT first?
So as it is a highly suspicious on CT scan,
yeah,
and it is resectable.
So my next question is tissue diagnosis mandatory before planning the treatment and considering the patient for either surgery or radiation therapy?
So if there is no suspicious node and it is only the pulmonary nodules and only the pulmonary nodule and it looks like resectable, then I think I should go without, and it is in the peripheral lesions. Yeah, so I think I would go without biopsy proven. But if I'm planning for lobectomy, then I would suggest biopsy before any other for further investigation.
Dr. Bihari, any comment? Any comment from medical oncologist or radiation oncologist?
Yeah, hi, Dr. Tapkire.
Yes,
This is Ashish.
hi, Ashish.
Yeah. So I think if you're planning for a surgery, I don't think a prior diagnosis is required. I think you can do it intraoperatively. But if you want to go for radiation therapy or SABR or something like that, I think a prior diagnosis will be required.
But sir, if I plan for lobectomy or bilobectomy, then I would suggest for a biopsy before surgery.
I think if it is not contraindicated due to any other reasons, or if the patient's general condition allows, this is mandatory to get a tissue diagnosis, preferably a core renal biopsy. Since this is a peripheral lesion, it is unlikely to get a biopsy through the bronchoscopy. So we need to get a transthoracic needle biopsy, CT guided, most commonly CT guided true cut biopsy before we plan any treatment. Are there any situations where we can avoid doing the biopsy? So if suppose general condition of the patient is not suitable for a true cut biopsy, patient has lot of emphysematous bullae. So in those situations, and especially if the probability of having a malignancy is more than 65%, if we are planning to do a surgery, or if we are planning to give radiation therapy, then this probability of having a malignancy should be more than 85%. So this requires discussion in the multidisciplinary board with the presence of radiologist. Yes, sir, please. Yes, sir.
See, the point is that whenever is a nodular lesion, biopsy is a must needed.
Yes.
Now,
yes.
with a molecular biology and energy and all these things helps in treatment the survival of patients.
Definitely, sir. So wherever
recently ESMO has given a guideline that less than T2 patients who has osimertinib has a survival benefit.
We will come to that, sir. We will come to that. So
as of my point is that whenever you have you do a biopsy, once you have performed biopsy, you can go for liquid biopsy.
Yes, sir. So it is.
As far as the biopsy is concerned, it's a peripheral lesion. It can be done ultrasound also. It's not, but because it's a very periphery, the risks of pneumothorax and hemoptysis is very. Would be. I think.
Yes.
In that particular.
Yes. Case. Yes. So if expertise is available, we can do an ultrasound guided biopsy also, and it is always preferable to get a tissue diagnosis before we plan the treatment. So now the pathology report has come as non-small cell lung cancer, NOS. So my question to pathologist is, are you satisfied with this kind of report, or do you want to do something else?
Yeah, good evening.
Dr. Anupam?
I think I'm
Yeah.
audible. Yeah, I think I'm
Yes, yes.
audible. Yeah.
Yes.
So as Vijay Saikia sir has rightly said that biopsy is very important. It is now mandatory for diagnosis. So after biopsy, if it comes a non-small cell, then we have to accurately say whether this is a squamous or adeno. For that, we can do IHC also. If required, we can go for IHC. That is why the biopsy is more important than the FNAC. In FNAC,
Very correct. Yeah, very correct.
So,
very correct.
so
In
it is
today's
better we
scenario,
go for the biopsy.
yeah,
So
very
then
correct.
we can
Very
go,
correct.
then we can go for
Yes,
the
yes.
IHC marker for
Yes,
differentiating
yes.
the squamous adeno and this thing.
Yes, very
Thank you,
correct,
sir.
Dr. Sharma. It is in today's scenario, it is very important to establish the correct diagnosis of either adenocarcinoma and squamous cell carcinoma. And we do not need a big panel of ISC markers. Only TTF1 and P40 are sufficient
Yes,
to differentiate
TF1, yeah,
between squamous
P40.
cell cancer and adenocarcinoma.
Another important point is PDL1. PDL1.
PDL1, yeah, we will come, sir, after, we will come to that later. So now, again, this is a question to the surgeons in the panel. How do you stage the disease? Dr. Sandeep, what is the role of PET CT scan in early stage lung cancer?
As per I think, see, in lung cancer, you cannot tell whether it is early stage or late stage. Before doing a whole body imaging, like you can do a PET CT or a brain MRI or whole body CT, like whatever you can choose. But like before doing all the investigation, it is very difficult to lung cancer is early lung cancer, because we have seen like small lesions, 1 centimeter, 1.5 centimeter lesions, only giving solitary metastasis to brain or like bone mets, small mets, solitary mets. So I think a whole body imaging and
You are not
stage
audible,
1,
Dr.
T1
Sandeep.
lesion onwards, everything. Hello? Hello?
Yeah. Okay.
I'm in a car, so it will be there. Now I'm audible?
Yeah, no problem. We got the point. Dr. Sandeep. So my
As far
question
as
to
the
Dr.
PET is concerned, it depends on the this attenuation values of the nodule. Nodules are basically 3 types. One is solid, one is subsolid, one is ground glass. The most of the adenocarcinomas, peripherally based nodules, carcinomas are mainly ground glass, presented with ground glass opacity. But that particular case, the PET scan is not very sensitive. For solid lesions, it's okay, but for ground glass nodules, so presently adenocarcinoma is very less sensitive. Less detection by the PET scan.
Okay, so
yeah, only mucinous, I think so. Some like previously termed mucinous adenocarcinoma, like adenocarcinoma in situ, now which is termed as adenocarcinoma in situ. Like in those cases, PET uptake may be variable. So it may not show PET CT uptake. But in
Because of
majority,
specific content, most of these cases are adenocarcinomas, peripheral based mainly.
So my next question to Dr. Nizu Pegu, if suppose this patient, we have done a PET CT scan and it shows SUV of 11.5 in the primary and the mediastinum is negative. There are no uptake in the mediastinum. So how do you proceed? Do you want to do invasive mediastinal staging in this patient?
If PET scan is negative, sir, then I think I will directly go for our planned surgery and intraoperatively we'll assess, and if any suspicious, then we'll send intraoperative frozen section for that node. If PET is negative.
If suppose there is a 1 centimeter node which is not FDG AVID, what will you do?
Okay, sir. Then if we have facility for mediastinoscopy and intraoperative frozen section, then at the same anesthesia, I would go for mediastinoscopy and biopsy of that frozen section of that node.
Yes, correct. So
may I interject, sir?
Yes, yes, Vijay,
as a
please go ahead.
pulmonologist, yes, sir, as a pulmonologist, I think because one thing, PET CT for a node less than 1 centimeter is not very sensitive. It may not pick it up. So in such cases, if we have the facility for EBUS, we can always do a mediastinal staging by endobrachial ultrasound also. EBUS staging plus along with plus with or without EUS. So if we combine EBUS with EUS, probably we can reach almost a majority of the lymph node stations. And those that are suspicious, sub-centimetric nodes, probably 7 or 8 centimeters, which may not be visible on PET, which may not show an uptake on PET, may be sampled.
So yeah, very true, Dr. Vijay. So if facilities are available for EBUS or EUS, then this should be the modality of choice for mediastinal staging. In case if we have a strong suspicion of positive mediastinal nodes, but EBUS is negative, then we can go for invasive mediastinal staging.
Dr. Ritesh, hello, I'm Dr. Indibar. Let me just intervene 1 second. Yeah.
Yes, sir.
Yeah, everybody is right. Yeah, we want to be non-invasive in the staging early lung cancer as far as possible, and PET CT scan is the standard now. That's okay. There is a consensus, no disagreement. The second thing is that there is a false negative in the PET CT scan, especially when it is less than 1 centimeter. So of course, the superiority of the PET is established over the CT scan, but the question is, dilemma is when 1 centimeter, and the EBUS and the esophageal and this thing biopsy, in the hands of the pulmonologists and our endoscopists, they are well trained. Here in Impal also doing a lot, but the question is, in the poor patient or elderly, in the this little bit invasive procedure is not available. Not possible. So what the surgeon has mentioned, go for the resection and do the mediastinal limb adenectomy and do the frozen section. That should be the standard.
Yes, that is the standard of care, sir. Correct, very correct.
I agree.
Yes, sir.
I agree. In our country, in our situation, we should not go on depending only on investigation. We should give the benefit. Maybe we may commit mistake 2 to 3 times. But what is that? I agree with Dr. That we should go ahead with the surgery so that the patient gets a benefit.
So the correct order of mediastinal staging should be, if available, we can go for EBUS, EUS because it is less invasive. If it is not available, then cervical mediastinoscopy at the time of surgery should be the procedure of choice for mediastinal staging. And now, of course, this we have already discussed about EBUS. And can we avoid invasive mediastinal staging? Is there any situation? So for peripheral tumors which are less than 3 centimeter, well differentiated cancer, and if the PET CT is negative,
if scan suggests less than 1 centimeter nodes less, and there is a nodule 1.5 centimeter or 2 centimeter nodule, we can avoid directly. We can go for a lobotomy.
Yes, sir. Yes, sir. So that's what I said, sir. For peripheral tumors less than 3 centimeter, well differentiated,
without having any retinopathy which is significant, and if we can exclude that it is not inflammatory, then we can go for it.
Okay. So if suppose this is a question to the surgeons. Yes, Dr. Sandeep, tell me.
Like while reporting a PET, I'm like as a reporting physician, I'm more concerned about like false positive than false negative. Like because PET CT majority mostly shows many times false positive also. So like I have to be very cautious in reporting.
So the PET CT has a very high negative predictive value, but in Indian scenario, you may get uptake in the mediastina, which might be because of infections or granulomatous disease. So in case of uptake, we need to prove that it is whether it is because of infection or it is because of tumor.
That's
Now,
why
suppose
that's why I was opposed about giving PET-CT right and left.
Yes,
Even
sir.
you cannot define infiltration cancer. And people become so afraid. And right and left giving PET-CT is that's nonsense.
So this is a trick question to one of anybody can comment, either pulmonologist or surgeons. So if suppose patient has a growth in the left upper lobe, and during the surgery or before the surgery, you do a cervical mediastinoscopy and remove this node, and this turns out to be positive, what will you do? Dr. Niju, Dr. Bihari?
Niju is there. Niju?
So this is basically the anatomy of the lymph node. So any node which is the pretracheal node, generally the division between the right and left side is along the left lateral border of the trachea. So any node which is on the left side of the left lateral border of trachea will become an N3 node for a left-sided tumor, and this will be an N2 node for a right-sided tumor. So if suppose there is a positive node in this location for a left-sided tumor, it will become an N3 disease. So this is basically the anatomical distinction between the right and left-sided tumor. Before this is a question to radiation oncologist and the surgical oncologist. If the patient has come to you, so how do you decide the best treatment option, whether the patient will go for surgery or whether the patient will go for radiation? So basically we need to do the cardiopulmonary assessment. So how do you proceed?
Ritesh, let me answer. Yeah.
Yes, sir.
We look in the workup already. We look the patient is fit and everything has been done. All the the therapeutic investigations. But as of now, the surgery will be given the preference if the patient choice is fit and resectable in such early case. But the question is, we have to take into account not only the staging, the pulmonary staging, the lungs status. So we'll do all the tests, the DLCO and everything. And if the patient is found to be unresectable, then then I would go for the radiation.
Any comment from surgeons, Dr. Niju, Dr. Bihari? How do you assess the whether the patient is fit for surgery if patient requires a lobectomy? Dr. Vijay, you can also answer. So basically
yes,
the pulmonary function.
So, so basically, as part of pre-op assessment, we also have to think of what type of surgery we're doing. Whether it's just a segmentectomy, removing a segment, you're removing entire lobe. And for that, a pre-op, at least a basic spirometry is essential, where we can at least predict what would be the residual lung function. Most important thing is residual lung function post-op. If we find that the residual lung function post-operatively is sustainable, then yes, if the patient is fit for surgery, he can go ahead for surgery.
Yeah, correct. So see, this is the basic investigation of cardiopulmonary assessment is pulmonary function test, where we get the FEV1. If FEV1 is more than 60%, the patient is suitable for lobectomy. The diffusion capacity of carbon monoxide is not available in all the centers. So basically we do the pulmonary function test. We ask the patient to do the stair climbing test or a shuttle walk test that we can do easily in the OPD also. And if suppose those tests are inconclusive, then we can go for VQ mismatch, the ventilation perfusion scan also, but that is of course depends on the availability. So the basic tests are pulmonary function test, and then for cardiac assessment we can do treadmill test. Now this is just a schema of the treatment of early stage non-small cell lung cancer. Now the treatment options, whether the patient will go for surgery. So before I go for surgery, I just want some points about the use of radiation therapy from either Dr. Indibor sir or Dr. Farida, one of them.
Yeah, nowadays, yeah, the standard is the SBRT. If we are going to give the radical radiotherapy in such a peripherally located less than 3 centimeter or even up to 5 centimeter, we can go for SBRT. For the local control, and it has shown that the disease-free and overall all the data is there that it is. And this thing, the Valor trial, and still going on reports, head-to-head trial with surgery and SBRT. Now, most of the radiotherapy is done when it is not resectable due to the patient's condition and other conditions. So we are giving SBRT, now we call it SABR also, stereotactic ablative radiotherapy, because the radiobiological process is such that we ablate it, isn't it? So we give the high dose, say usually the standard dose is around 20 gray in 3 fractions, or we can go up to dose escalation if the disease load is more, up to 5 fractions. And so that can be done by the various techniques. We can use the CyberNav, or we can use the IMRT technique, or we can use the tomotherapy also. So by using these various techniques, whatever available facility, so we will go for the stereotactic body radiotherapy in such a scenario. And it's peripherally located, and the long-term radiation effects and the others are very less here. So it gives
correct,
yeah.
Okay. So any comment from Dr. Farida?
Yes, sir. Now, the previous trials which you have seen, the STAR trial and Russell trials, though it's the sample size is less, but the trials, whatever the analysis they have done, it's the SBRT is non-inferior to lobectomy, even in operable patients also, especially if patient wants to, if patient refuse surgery, or it has a high risk for undergoing surgery. And this patient has a peripheral tumor, so I think as if patient wants to go ahead with SBRT, I think it's a better option.
Yes, so correct. In special situations where the patient either denies surgery or patient general condition is not suitable for surgery, we can go for SBRT, which has very good results. But whatever sample size was there, it was small. And as of now, the standard of care for a resectable early stage lung cancer is surgery.
Yeah, meeting.
Yeah. So coming to the surgery part, so how do you proceed, Dr. Nizu? You want to do any lobectomy, or you want to do sublobar resection?
The surgery of choice should be the anatomical resection, that is the lobectomy. Only if the patient's general condition not permit, then only we should advise for sublobar resection, like segmentectomy or wedge resection. Otherwise, lobectomy should be the standard of choice.
So which one will you prefer? If suppose general condition is not suitable and you want to do a sublobar resection, so what will you choose, segmentectomy or a wedge resection?
It will depend on how the margin I should get 2 centimeter margin all around. According to that, I should decide actually.
So if you have to choose if you sublobar, yeah, go ahead.
If you give me the choice, then I will go for segmentectomy, sir.
Yeah. So segmentectomy is more anatomical resection, and it has shown that it offers a better oncological outcome as compared to wedge resection. Yeah. So what about the mediastinal nodal resection? Would you be happy sampling or dissection?
If preoperative investigation shows there is no node, then I should go for only sampling. And if there is a highly suspicious, or if then I should complete the mediastinal lymph node dissection.
Okay, so what are the lymph node stations you are going to address? This is a right-sided tumor, right upper lobe tumor.
Right upper lobe tumor. That is then state with N1, that is ipsilateral peribronchial and ipsilateral hilar node, and the mediastinal node, N2 node, up to the N2 node.
So we need to take at least 3 N2 stations and
N2
all
stations.
N1 stations. Yeah, so N2 stations for a right-sided tumor will be 2, 4, 7, and 8, 9. Yeah.
8, 9. So.
Yeah. So these will be the N2 stations. So we need to take minimum 3
Three.
mediastinal, 3 N2 stations to correctly identify the nodal status of the patient. So we have seen that the mediastinal lymph node dissection does not increase the overall survival, but it is very important to do the mediastinal lymph node dissection to correctly identify the stage of the patient. Because in many of the studies, it has been shown that properly performed mediastinal dissection will identify concealed N2 disease, and that will change the management, further management. So this is the histopathology report of the patient. Any comment from the pathologist? How are you going to gross the specimen? And Dr. Anupam?
Hello.
Yeah, Dr. Anupam.
Yes. So grossing part is very important. Actually, it is a long procedure. The grossing first starting with the fixation, then the orientation of the specimen, identify the bronchial and the vascular margins and the hilum. Then we have to look at the tumor, location of the tumor, then measure the size of the tumor, then measure the distance from the resection margin, then vascular resection margins, parenchymal resection margin, and the visceral pleura. Then we have to measure the distance.
Yeah,
then
correct. So it is.
Yes.
Yeah, go ahead.
Yeah.
So it is very important to, it is very important to put the specimen, once it comes out of the body, within 1 hour, it should go in the neutral buffer solution, neutral formalin solution. And then we have to keep it fixed for
and in case of
minimum
lung,
10.
we have to infuse. Yes, in case of lung, we have to infuse by a syringe that formalin inside the parenchyma.
Yes,
it is very important.
Because if it is not properly fixed, it will affect the molecular pathology. See, because if it is an adenocarcinoma, we would like to get the EGFR, ALK rearrangement, all the molecular profile. So if the tumor is not fixed immediately after the surgery, and if the fixation time is not adequate, then it will affect the molecular profile of the patient. So it is very important to do the proper fixation of the disease. So now this is a T2N0 stage 1B disease. So my question to Dr. BJ Sekia, sir.
Ritesh,
Yeah, Vikas?
5 minutes more.
Yeah, we'll finish in 5 minutes. So how do you decide about the adjuvant treatment, sir? Dr. BJ Sekia, sir.
I would like to know about the PDL1. PDL1.
Yeah, PDL1, you can say it is more than 1%, sir.
More than 4%. Then I would like to add with platinum-based chemotherapy, which atezolizumab, which has come new trial.
Okay, sir.
So I like to use some immunotherapy along with chemotherapy.
Okay, sir. How many cycles would you like to give?
If it's a early lung cancer, I like to continue 4 cycles of chemotherapy followed by atezolizumab for 2 years.
What is the advantage of giving immunotherapy, sir, in this situation?
Because of ESMO published data, they say that after giving 2 years, they have got a very good advantage.
Yes, sir. And what will be the cost effectiveness of this immunotherapy, sir?
That is a different issue. That is a point is we cannot discuss. But ideal situation is not always ideal.
Ritesh, can I pinch in for a moment? Can
Yes,
I
sir.
add some moment?
Yes, sir.
It is Dr.
Yes,
P.S. Roy here.
please.
Ritesh,
Yes,
as
yes,
far as SARS cytosine is concerned, recently published data in 2021 ESMO says that if you are adding chemotherapy on immunotherapy, so it is immunotherapy, 4 cycle of chemoimmunotherapy followed by surgery, followed by 2 years of maintenance atezolizumab, which will give you ORR response rate around 32%, which is against only chemotherapy, which is around 22%.
For which
And it is
stage?
Yeah, early ORR. Well, I'm talking about the ORR. So we are giving anesthetic, na? And that is equivalent to PFS benefit of around only 3.5
we are discussing
months.
about, yeah.
Okay.
So we are
So
discussing about early stage lung cancer.
Yeah, I'm talking about the early stage only. So we are giving overall response rate.
Okay.
So response increases. That means you are going for more and more number of surgery. But as far as the survival data is concerned, it is only giving you 3.5 months PFS benefit. OS data is not yet mature. And yes, you are right. At the cost of around 10 to 12 lakh penny, that is not an issue for our Indian scenario. But yes, when you are talking about the scientific thing,
if the same patient has, if the same patient has an adenocarcinoma histology and the same stage, what would you do? Will you change your adjuvant treatment? Instead of squamous cell cancer, it is adenocarcinoma.
Okay. In that scenario, if adenocarcinoma, what you are talking about, the GFR status is positive. You meant to say that?
Yes.
Okay.
Yes.
Then we have again.
We have got osimertinib.
Yeah, we have osimertinib because in that scenario we won't pinch in immunotherapy. In that scenario,
But this
we'll go
has,
ahead with the chemotherapy.
But osimertinib has not shown any overall survival benefit. It has shown
Yeah,
only
right.
DFS benefit.
You're right. We have to see that the data is immature. That is the reason probably we are not seeing OS benefit. So once it is EGFR positive, there is no question of immunotherapy. So once you will go for immunotherapy, means you are pretty sure that it's not adenocarcinoma, it is not EGFR mutated analysis. That's it.
Do you want to comment on this trial also?
My point is that from ESMO recently they said that osimertinib, they have not reached they have gone very good result with osimertinib, and median survival not received yet.
Okay. Ritesh, I was saying that it is only showing you DFS benefit. So you have to take with a pinch of salt whether you are going to give 3.5 months DFS benefit at the cost of that 16 lakh to 20 lakh cost. Okay.
That's what I was thinking.
But anyway, when you are discussing science, definitely we have to take this also.
What about this trial? Do you have anything on this trial, EVAN trial, which is a comparison between erlotinib and standard chemotherapy, and this has shown OS benefit also?
Have you gone through the ADURA trial?
Yeah, ADURA trials, sir, I've gone. I'm just asking about, sir, whether do you have anything on this trial, sir?
So to discuss all the trials will be difficult now.
Okay, no problem, sir. So
I'm not very comfortable.
Okay, so my question to the radiation oncologist: what will be the role of adjuvant radiation therapy in a resected lung cancer? Suppose this patient, do you want to give adjuvant radiation therapy after resection?
Replace?
Yes, sir. So please go ahead, sir.
Yeah.
Okay. It is, as of now, there is a controversy of post-operative radiotherapy in early lung cancer. The trials are showing results. So, but all of us know that the earlier ANITA trial shows that the subset analysis, when radiation was given, the recurrence rate and is much better, and the other response benefit is there. But the earlier trial, the trials has shown that radiation by giving a port in the early stage, it has decreased the survival like that. But then there is a lot of controversy, as you know now. The earlier the radiation was given by 2D or by not the standard or not the newer techniques. Nowadays we have got the even proton beam therapy. So the radiation, some study has shown that after 7 years, the survival is decreased like that if the long-term survivors, radiation group, the arm. So these are all controversial. Nowadays, with the advent of the newer techniques and the new radiation therapy, like heavy beam and a proton beam already available in India. Let us talk science, whether it is available in Northeast or not. But then it is showing that board is showing a better result, yeah, where in such, yeah.
Yeah, Dr. Ashish, Dr. Farida, any final comment before I conclude?
Yes, sir. I don't. Yeah.
Yeah, I think as of common consensus now, adjuvant radiation is only given if there is a positive margin, or if they incidentally they find N2 disease during surgery.
Correct.
So I think that is the only situation in which adjuvant radiation is given as of now.
Correct. Very correctly said. The only indication in early stage lung cancer is positive margin. Correct. Dr. Farida?
Yes, sir.
Anything to add?
Yes, sir. Rightly said by Dr. Ashish, sir. So, and I think we can go ahead with now the newer technique with 3D CRT or MRT, planning for if there is a not positive or a margin positive for me. But as of now, I don't think with this scenario, I don't think adjuvant RT is required.
Okay. So,
I think.
Yeah, we can conclude here. Thank you very much for the excellent discussion. I would like to thank all the panelists. Thank you, Vikas.
Yeah, thank you, Ritesh, for the wonderful moderation, and thanks to all the panelists from AONEI and other members and all over Northeast. Thank you for your precious time. So with this, we end our today's scientific sessions. We'll go ahead with the next topic, that is quiz session. So even I request other people also who can join in and do it online if they are free. But prize will be mostly reserved for the students and PGs and other people. But we'll have questions, around 30 questions are there. The time will be 15 minutes. And after that, we'll have a GBM also. So I request all the AONEI members to be present for the GBM. In the meantime, you can have a small break of 15 minutes. The others, students and PGs and other people can join the quiz session. Ravindra, you are ready? Hello? Ravindra?
Yes, sir.
Yeah, you are ready. So we'll start the quiz session. You can start it. So the quiz session is Google form, and everybody has to log in and fill the form, and the time will start. You can copy the link and start the quiz. After that, you will be able to see the questions of multiple choice, 30 questions. Allotted time is 15 minutes. We'll start. Ravindra, you take over.
Sure, sir. So everyone has to log in this link in your browser. Once you log in this link in your browser, you will be found a page which has a button, start the quiz. When you click on that button, you will be able to see the questions in multiple choice format. So answer all 30 questions in the allotted time, which is 15 minutes. So just I'm putting this link in chat box also. So you can just click on that, and
the link is in the chat box also. You can copy it and paste it on your search bar, and you can directly connect there.
if anyone is finding any problem, you can type in the chat box.
Yeah.
Dr. Vikas, can I start the timing?
Yeah, you can start the timer. Prashasti, you have to copy the link into your browser, either Google browser, and click it. It will go to the quiz session directly. I hope you copy the link exactly. There might be some error from your side. It's opening clearly.
So this is very simple link. You have to just type www.mightyduo.com/quiz. After clicking on that link, you will find the button start the quiz. When you click on that button, the question will automatically appear.
I think I'll share the screen from my side to make a demo. Yeah. Ravindra, I'll be sharing my screen. Yeah. So I typed the string, I've gone into it. It will take me to this page. And I can start the question. So the questions, I think everyone can see the questions now, Ravindra, right? You can share the screen, Ravindra.
Yes, sir.
Yeah. So I think everybody can see the question now, right?
Right, sir.
Now some of the faculties can also join and answer the questions if they are interested. We'll have a GBM after 15 minutes. Bhuyan sir is there? Bhuyan sir? Sir, आपका speaker is mute. Yes, sir. I sent you the WhatsApp, sir, regarding the GBM.
हाँ मिल गया
So we'll start after 15 minutes. 12 minutes
yes,
are.
yes. I'm there. Yeah.
I think
You
everybody
take the
is
quiz.
there. Yeah, everybody is there from Shillong. Danisha is there. Dr. Zotan Kima is there. Dr. Ashish is also there. Ashish, you are there, I think.
Yeah, Ashish, I have seen.
Yeah, Ashish is there. Dr. Partho is also joined. You are there, Dr. Gayatri Gogoi.
Ravi is there. Ritesh is there.
Yeah.
Arunachala koi.
Arunachal Rubu is not yet there, I think.
Rubu ko phone lagao.
Yeah, I'll just call her, sir.
I think she'll join in time.
Yeah, I'll just remind her so that.
Okay.
Calib, you are there, na, for the GBM?
Yeah, I'm here with us.
You are okay now?
Yeah, ready to join Monday.
Good. 7 minutes remaining. Nipendra, you are there, na?
Yes, sir, I'm here.
Yeah, so we'll start after 5-6 minutes.
Yeah, we can.
Vitesh, you got the account card detail? No?
Now I request all the quiz participants to kindly submit their answers. We have 2 minutes left only.
Only 2 minutes left, so request all to make it quick. Ravindra, you have stopped FB now already? Yeah, okay, I can see.
Now only 1 minute left.
Thirty seconds.
30 seconds left.
I think we can all start the video of everyone so that we can see each other at least now after the quiz. And since now it's a interactive session. Jodu, you are there? Dr. Jodu Nath.
Yes. Very.
Welcome. So the time is up for the quiz session. I hope everybody has submitted it. Ravindra, you please do the tally and send me on WhatsApp the results. Okay.
Sure, sir.
So without wasting much time, we'll start our GBM. I request Dr. Bhuyan sir to start the GBM, and I request all other who are there in the Zoom who are not the members kindly join us after maybe half an hour. Till the time we join. Thank you.
Right.
Yes, sir.
So thank you, Vikas.
Yes, sir.
So I welcome all the members who are on the line. At the moment, I see 43 people are there present. So I welcome all of you to this meeting. But if I go for the quorum formation issue, quorum is not formed because we are at the moment 139 members in AONEI, and at the moment we have 43. We have seen it every year that we do not form quorum for general body meeting. It's an issue every organization is having, and there is a system called a break for some time and reassemble again. So virtually, I break the GBM for some time. I mean, I have broken already, and then I have again reassembled all of you, so we can proceed on the GBM. Yesterday, I had told the consequences leading to this meeting in online situation managed from Shillong, all done by our General Secretary, Vikas Jagtap. I again say that I am very sorry, and in fact, with all executive members are very sorry that in spite of serious effort, sincere effort from Dr. Arup Roy Burman and his team in Agartala, the meeting could not be held physically at Agartala. You all know why. This is a COVID situation. It is not possible. Anyway, so let us proceed. I'll request Secretary Vikas Jagtap to read out the last GBM of AONEI resolutions, the reports. Vikas.
Yes, sir. So in the
Somebody's mic has to be switched off. Jodu, tomorrow sort of khabdo hoye ase niki? Sister Bilake. all of my, okay.
So
Okay.
the last GBM, the main
Yeah.
So in the last GBM, the major issue was for the election. So we decided that in the last meeting also that election will be held physically in the current year, that is 2012 at Agartala. But since this conference is also cancelled and it is online, we will not yet able to hold the election because the term is already due and we are waiting for the new committee. In the meantime, because of the COVID, we couldn't conduct many of the meetings, and in between we had a online meeting last year. This year we had one midterm conference at Arunachal that was been done, and we decided to continue the same committee till the next election is held. And other newsletter was asked to continue the publication, so that is still pending issue. Otherwise, there was not other major issues. Account details were already updated last year, so I think Ritesh will be updating now the next details. Yes, sir. And the last year activities, coming to the last year activity, we have annual conference last year in 1920 March 2021. That was annual conference. The midterm thyroid CME was held in December 2021 by Dr. Rubu Sunku at Naharlagun. And two awareness programs were done by Dr. Gayatri Gogoi. One was in Tiok and other was in, I think, Nalbari.
There were four, I think, Vikas.
Yeah. And other awareness programs were also done by Dr. Arup Rai Burman at Agartala. So those were the activities. We didn't have any online meeting. We tried to conduct, but then at the end we decided to go ahead with the Arunachal CME. The executive body committee was there meeting in November 2021 when we asked Dr. Arup to continue the preparation and report by December 21 for the preparation of the next meeting. But because of many issues, the meeting was transferred and we tried to hold, but because of the new COVID restrictions, it was to be done online. So again, the major issue is we are not able to conduct the election this year also because of that problem. The other thing which we need to discuss is the
Yes, it's okay. It's okay. It was about the resolutions that we had last year, and out of the resolutions or decisions taken, some we could do, some we could not do.
Yes, sir.
The election we could not do last year. We thought of doing it this year. Again, because of the annual meeting being in virtual mode, election, the decision has to be taken by the general members this time. So we'll discuss that issue because you bring it up, right?
Yes, sir.
So
other,
I think,
other thing was newsletter. We had newsletter till 2020, but since last year the newsletter is not yet published. I think Dr. Kelly will update soon. The website, there was some issue, so we had already done the new website. I will be updating you. I'll show this. I'll share the screen with you regarding the website, so what is done. Account, I think Ritesh, you can just update the account. Ritesh, you are there?
Yeah, so as of now, good evening everyone. As of now, the account balance is 20,45,526 rupees. The income tax has been filed last month and yearly audit has been done last month.
Yeah, so this is the around 20 lakhs 45,000 is there in the account. Income tax and audit report has been filed last month. There is some payment due for the Naharlagun conference to Dr. Sunku. So she submitted the bill, but just because of one issue I had withhold. For the current conference, since it was in annual mode, we are not asked any sponsorship. Only AstraZeneca, who sponsored the session, which Dr. Partho and Dr. Umesh has given a talk, they had sponsored 1 lakh. And we had asked the Mighty DO, who is our conference arrangement partner, with the 40,000 rupees to maintain all the online sessions, live streaming and all this issue and email and everything. So that will be paid. So we will still be left behind with around 20 lakhs only almost. And some payment will be done to Dr. Sunku. And obviously Dr. Sunku will be getting around 3 to 4 lakhs from the sponsor. So that is yet to be deposited. So that is for the accounts right now. So I think the major issue to discuss is, I think Dr. Caleb will update regarding the newsletter in the meantime. Caleb, you are there?
I'll clarify one
Just
point,
1
because
minute.
I'll say a few words here. Caleb, before you regarding the finances, we have already decided in earlier things that the satellite meetings or midterm CMs, whoever is organizing, the central committee will at least give a grant of 25,000 rupees for the meeting, and they can also generate fund on their own if possible, and it is always good. But those every fund will come to the to the main account of AONEI, and the expenditures involved will be reimbursed by the AONEI. This was the decision that Rubu will earn about 3 lakh rupees from sponsors, and she will also receive a grant of 25,000 from the main committee. Is it Vikas?
I think it was 10,000, sir, if I remember correctly.
10,000. Okay, this is 10,000, and the actual bills which she will have will again be reimbursed from main account.
Now everything
Right.
is coming to AONEI account only. All the sponsorships are coming since last
So we,
3-4 years to account only. And
so
we are paying
basically, if we
in
do
check.
a program, we also earn money.
Yeah, and we are paying always in a check. I had stopped all the cash transactions for last 4 years. Even the new memberships are online only. Yeah, I forgot to update regarding new members. So there are 4 new members: Dr. Jyotiman Nath, Dr. Rituparna from BBCI, Dr. Navin from Nigrims, and Dr. Duncan Kanikar from BBCI. So I welcome all of them also in the new committee. And so all the current sponsorships are coming into the account, and all the payments are done in the check only. Even the students who got the prize last year or the previous years also, they were also given in the check only. So since check was not able to give them in person, I had done all the NFT transactions to all of these people over the last 2-3 years, whatever is going on. So all this has been done in the NFT transfer only. Nothing has been given in cash to either their account or to the vendor directly. So that's what. Yeah, Jodu, you are saying something in between?
Yeah, Jodu had something
hello?
to say.
Yeah.
Yeah.
Yes. Can you hear me?
Yes, you are audible, Jodu.
Just present balance is 20 lakhs in our account. I mean, present in our corpus fund is 20 lakhs.
Yeah.
And how much actually totally we have? We need to give for the owners of conference. I mean, Itanagar one also, no?
Itanagar
Out of
payment due is 1,48,000.
we have to give. It is already been deposited in our account, or you have to give?
Not yet deposited.
Okay. So this
Once
must
they,
we have.
the sponsors are arranging, they generally take time.
That is okay. That's I wanted to know. Give how much will remain ultimately.
So other hotel was, so total is coming to around 3 lakh from Sunku's side. The bill also coming to 3 lakhs almost. That's
okay, that is okay. I mean, you have to deposit it. Okay.
Yeah,
And
so
we already earlier discussed about FD. Those things we made over or not yet done.
FD issue is, as per the new government guidelines, we cannot have a saving account.
Yeah,
Actually, that
we
is
cannot
the
have
main
saving account. We can
and
make
we
FD.
cannot have the FD also. All the current account will not be having FDs. So that was also an issue. So once we go for a FD, they will ask us to convert to current account, and you will not give anything.
Savings account.
Ours is current account or saving account?
Right now is still saving account.
Oh, it is great.
Yeah.
Account has to be changed.
So that needs to be done, and right now they are not yet objected, but once they object, that has to be changed to current account.
Normally we should have a current account.
Yeah, now everybody has to have a current account, no more saving account. So that's a
Because
yes, sir.
Because some banks are offering sweep accounts. Sweep, that means your surplus money will go into an fixed deposit, short-term fixed deposit, and you will keep on earning little more interest. And whenever you issue a check, that sweep will be broken. That XD will be broken and brought out. But
Sir,
this is very cumbersome. At the end of the year, when you start accounting, this is becoming a little cumbersome for the accountant.
Sir, but that is not allowed with the association accounts. It is
Okay,
allowed for
fine.
the personal or the group of people.
Personal accounts, okay.
Yeah,
So
but when it comes to association account, these rules change.
society accounts, it is not possible. Okay.
Society account is difficult. I asked last time to CA, he said, "Ki, sir, current mein convert kar dijiye and maintain as a current account, as, and it will be easy." But so far we are paying the tax. Now at least the tax part is cleared for the last 5 years. No more things are coming. No more letters are coming. So that is done. Since last 5 years, audit reports are done. Tax are filled on time. There is no delay. So that is being maintained.
Okay. Another thing. Can we buy something like a bond? Say we buy a bond.
No, sir.
Bond.
Association, sir, we cannot use the
Cannot buy.
Yeah. Association cannot invest. Association cannot.
So clarify those things with
official
the banker.
purpose. Like suppose that there is an office, you give some salary to the staff, buy some table, buy some stationery, printers, computers, whatever. That is okay, but not as a investment purpose. It should be as a use purpose mostly.
That has to be financially permissible, no?
Yeah,
the rules must permit.
Yes, sir. And
right.
Yes, sir. Caleb, you were
go ahead. Yeah, Caleb, please.
So the last newsletter came out 2 years ago when we had the physical conference. So subsequently, last year, because we did a virtual, we were, initially I started collecting some articles, but the response has been very poor. Last year also, whatever guest article was ready last year. And then because of virtual, we decided against doing a physical newsletter. So this year again, we thought probably we'll have a physical conference, and we thought of going ahead with the articles. We started collecting it, but again, because it has become a virtual, we didn't do. And again, I didn't get any articles. Of course, if we had a physical conference, I would have pushed people, because normally it's all only with push that people send articles, except for the report of the midterm CME by Dr. Rubu Sunkud. I didn't get any articles as such this year. So that is the status.
Yeah, what I suggest, at least we can go ahead with a, rather than physical, just the PDF copy online newsletter. So we can ask some 2-3 people to submit the articles. The reports are already there with me now. The last year's activity, Dr. Gayatri has already sent, and we can publish it not in a physical format, but just like an online format. So I think that we can go ahead with the next 2-3 months. So at least this year we will do it. What others say? Any opinion?
Yes, comment from others. Gaurav Das has written something in the dialog box.
Yeah. So all those abstracts, he's saying all abstracts we already have. So you can include the abstracts also in the online. Yeah, it will be in the online newsletter. And last year abstract also we can include in this year newsletter, I think. So that can be done. We already have the abstract in the mail. So that can be done. I think, Caleb, this is okay.
Okay.
So rather than printing it, we'll just go ahead with the online format totally.
Yeah.
Okay.
Instead of going blank.
Yeah.
So we have this. At least this much is with us.
Yes, sir.
Yeah, Vikas. That's I think very good idea. But instead of why not continue with the online format of our newsletter instead of printing it, because it doesn't reach us. I don't know where it reaches.
That's what I think. We'll continue with the online only, right?
Online
this
only,
year.
I think so.
Whenever we have a physical conference next year, we'll print it and inaugurate at the time of online also. So what we did in Gangtok first time, we had a proper inauguration of the but that will we do whenever we have a physical conference. So at least this year we'll finish the this year ka newsletter online. Next year, if we can do it in a physical format, we'll have a physical print version also. That is what we try to say. And the website, I'll just update. Caleb, I'll just take the liberty to do it from this side. So website.
I have a thought.
Yeah, Ritesh.
This is Ravi Kannan. See,
yes, sir.
The proceedings of this meeting, why don't we put that in our
as a GBM minutes?
No, not the GBM. The academic meeting. You can request everybody to give a written text and put that in the proceedings of this AONEI.
That's right.
A
That's
small
what we
summary
can-
of their talk. A small
Yeah.
summary of their talk.
Oh,
Yeah.
why a small summary? They can give the entire talk.
Yeah, that is also okay, sir. Then no problem.
Yes, yes.
So I am sharing the screen right now. So this is the current AONEI website. I think everybody can see this.
Yes, yes.
Yeah. So we had this AONEI committee and everything is already there. I am not updating the member list because it is an online format. So I'll be just putting the members' name only, not their contact and email IDs. Constitution link is already there. Last year ka conference we had online. So last year conference recording was done. So these sessions are also there on the website already. Everybody can go back and live. This year conference, once we finish by Monday or Tuesday, we'll be uploading all the 3 days recording session. Also, we had uploaded the newsletters which were published till 2020. You can just click on the link and they will open into the new tab and the newsletter will be open. I'll be putting the photo shortly by next week and this will be updated. Okay.
Get all the photos of the activities in the last 1 year.
Yeah, I'll put it that so that will be done, sir. Okay.
Okay.
So this is there, www.aonei.org. And I had activated the email also, that is aoneioncology@gmail.com. I think you all have received the mail through this now, this time, last year also. So that is being maintained currently. And I think now Calip can put inputs for this website. I'll share the details with him also. Okay, Calip?
Because do you have emails of all the members, 139 members?
Yes, sir. Almost all are there out of
See,
139. Some are bouncing back. I tried to call, but some numbers were changed. But almost like 20, 15 emails were bouncing.
Will be lost, I think.
Yeah. And
the other thing is that in the group, WhatsApp group, about 100 members are there. So there are few members whose phone numbers are they are not included in the WhatsApp group. So
Yes,
try
sir.
to find out if they can be put.
I'm trying to include many. Last month also, I tried to put up more. Last year also, before the conference, I included many who were missing. I'll try it again, sir, definitely.
Yeah. Okay. Update, that's the thing.
Any other issue? Kannan sir, Goswami sir, or the senior members, other Dr. Khamo?
Yeah, our elections, no, why don't we go online? ASI does it. So many associations are already doing it.
Yes, sir, we can go ahead with the online. I need permission from everybody if everybody is okay. But the problem is, even though I go online, everybody has to actually go and vote online also. So just if 40, 50 people only go online and register and put their vote, then again it will be difficult.
It will encourage greater see, ASI, you know, they have, I don't know how many 20,000, I don't know how many 8 lakh, 9 lakh people.
Yes,
and
sir.
everybody does not vote, but a large majority will vote. Let us try it, no? Toss it around.
If possible, because it is good and the way things are going on, I think we should think of it.
Yes, sir.
Think of it. And Ravi can give the input from ASI or whatever is source. Discuss it out, and if possible, we go ahead with an election online mode.
Sir, I'll do one thing.
Because we are postponing, it's not good.
Yes, sir. I'll do one thing. I'll check with the other association like ASI and our ROI also has done online election. So how much is the cost coming? Because
expenditure also is important.
Yeah. So that cost and everything I'll put up in the executive committee meeting. If that is approved, then we'll go ahead with the online election also. So I'll circulate it as maybe I'll try it by next 1 or 2 months.
Okay, note it down that we have decided to look for online mode of election. That's important resolution for today.
So everybody agrees with online now. That is clear. Any
Members?
objection to online election? Or I'll take it
Online
as
election. Online election.
Okay.
Yeah.
We can go for online
So
election.
what will be the? I mean, okay, good.
It will be a link only. So link will be shared with only the members, and they have to vote. But I don't know the exact detail how much it will cost because we have to ask some partner. Yes, Caleb.
Yeah, actually, we done good for our Indian Association of Surgical Oncology also. So it is not very expensive. Should be around 1 lakh or less than that only. Maybe for us, because it's a smaller association, it might be much cheaper. But what I wanted to raise the point was that first we have to come up with a system of asking for nominations.
Nomination.
And
Yeah.
only
It will be a
if there are more
step-by-step
than
thing.
no, only if there are more than adequate, more than required number of people are applying. Only in that situation, only if the situation arises that election is warranted, only then we need to go for the election. So if we just ask for it, normally so far, I don't think we've had multiple people applying for the same post. So we may not have to do an online election at all.
Yeah,
It's
we've never
just
had an election in that sense, you know, it has always been unanimous. But as we grow, this will happen.
Sir, what if there is no nomination for some particular post? What we are going to do in that case? Like online, see, most of the organizations which we are talking are big. There are more than 2,000-3,000 people in those organizations. So somebody is always there. We have, obviously, we had not much nominations in the past experience. So what I can do is I can ask for the nominations before. If nominations come, then we'll go ahead with, or anyway, if there is no nomination, that post will be blank.
No, because if you ask for nomination, that means you are going ahead the election. Once somebody submits a nomination, then it will be difficult to reject it. So single nomination.
What should be the way?
That will be a complex situation then. That will be a complex situation then.
Sir,
That's also true. So
Suppose for
better.
a particular post, one nomination comes, then he will be the winner only.
Yeah.
And suppose there is no
that is the thing.
application for a particular
For
post,
another
the
post.
executive committee has to decide depending on interest
No,
and
it will
efficiency.
be-
They have to bring out.
Jodu, executive committee cannot decide the election members. It has to be general body again.
So again, general body.
So the thing becomes same.
Presently annual.
So I
Presently we
think
are
we
having
should.
annual GBM only.
So I think
No,
we
I
should continue as it is till we have a next have a physical conference, and then we can decide in the next GBM, sir.
I think
Because-
what Ashish is telling is true. What I say, because try to find out the pros and cons of doing this online election process. All right, and then put it in a meeting. Even you can put it in an executive meeting of ours, which we can hold anytime. Especially in summertime, probably it is possible. And we discuss and put it onto the general body for discussion and decision.
What my thought is, we can do the online election and complete it before the general body meeting. And if there are vacancies, we can bring this up in the general body meeting for the general body to decide.
Next year.
So this one minute. This committee is functioning since when? Present committee.
2017, 4 years already, second term.
Okay. Then we have to change. I mean, that's what my personal opinion is.
What I suggest, that's just opinion. Suppose that this COVID wave is going to come down by March or April. Why don't we immediately take a single day CME or conference in Guwahati, and in the evening you put a GBM and election directly?
No, because
that won't be a general body.
I think
CME will not be a general body, Vikas.
Okay, but
because 1 minute, I have seen in many organizations this process is going on, election process. Nobody is continuing like this actually. In other association also, their activity is continuing, and their term is same term only what it was before COVID. So I think we have already continued one more term, already 4 years, and then we must have election. Whatever the procedure we should change. I mean, if we can nominate, it's a different issue, but we should have. Yes, sir.
Jadu, how did the ASI Assam branch is doing? What did they do regarding this? Assam branch.
We had the elections.
How did you do that? No. You had a meeting, that general body meeting?
No, we invited. No, sir. We invited like same for nomination and all.
Okay.
And then we then we actually had less number of nominations. So ultimately, unanimously selected. I mean, based on those nominations, there was a single person only for president post, and secretary also was like that. So it was election process only.
Now, who made the decision? I mean, election. There
We
has
have
to be some
selected
election officer.
Election officer.
Election officer. Okay.
We have to appoint somebody as an election officer
Yes,
who will be the
yes,
overall
yes.
in charge of this process.
Yeah.
Yes.
So that will
But
do.
president and secretary will be always there.
Yeah.
But others, members, the treasurer and our editor, these are very important. Anyway, because discuss it with other organizations and try to find out, because it is high time.
Yes, Khaled.
Also, before
Khaled?
the online thing started, no, many of these associations were using postal ballots. So if we find this online thing to be very complicated to start with, we can also do postal ballots. We just mail it out to 130 people, and whoever sends it back, we take it.
Sir, I'll explore the possibilities. I'll come back.
Can we use that WhatsApp group also? Suppose one election, committee like that, they will have one group only, and we have to upload.
Okay, fine. I think we have to do something. So Vikas has to take the responsibility of this.
Yes,
What I suggest is that make a time frame. So 1 or 2 months you take within this initiate. Find out what is the way by going in the WhatsApp group, going to personal emails, or by what. So I request Rabi also, Caleb, Jodu, everybody, and all others who are listening, please give input to Vikas, and we'll have to decide a way to do it by not physical, but by electronic way. That's the thing.
So I
Before
think
the next,
we
can
use Doodle also. WhatsApp, because the IME election here in Sikkim also, sir, we did it through WhatsApp only, sir. That way, it's like everybody participated also, it becomes easy also.
Yeah, we will put a nomination first. If there are single nomination, that will be elected automatically. If there are 2 nominations, that will be only put up for the voting. Yeah, that is also a good idea. I'll go through it.
No, I think you have to appoint the election, and he will put up all these things. You as a secretary should not do.
Yeah, I'll appoint the election.
We can appoint an election officer right now,
Yeah.
who will do this, and Vikas can help. Maybe Caleb can take it. Maybe Caleb is already there, no, in the executive committee. So someone else who is not there in the present executive. Ravi can do it. Senior member out of the executive committee at this moment.
Yes,
Ravi?
yes, I also.
Yeah.
Okay.
Do you think Ravi can do it? Or Ravi will do it?
Okay.
Yeah. Caleb, you tell me.
Sir, what I was thinking is, so not traditionally, how have we been? See, I've seen only 2 or 3 AONEI annual conferences, maybe 4 or 5, maybe since 2016. So traditionally, what has been happening? So usually in every association, the nomination forms are out. Nomination is asked for, but we have not done all these things. So every time we go to the GBM, and in the GBM, people, it's kind of people are.
It's sort of proposing and seconding, something like that.
Yes. So
we had been doing in an old fashion.
Exactly. So if we have been following the same thing, it's just that what is different this year is that we are not meeting physically; we are doing it virtually. The same can be explored today. That same thing can happen now. I mean, what is preventing? I don't understand.
The other members, we have 39 people online at this moment. Link. Yes, we can make a decision.
Yeah, then you can have an election now if anybody wants to take.
We can we can make someone an election officer, and we can do it.
Kannan sir is already.
So the election process, and they can very well then apply for that. I think that is the best one also. I think rather than proposing.
Yeah, so then Ravi Kannan sir is already a election officer. So
Yeah,
sir,
Ravi.
Because sometimes we can hear, oh, you have.
Yeah, Jadu.
Yeah, sometimes people are not happy. In previously, I have seen. So some may want to become president also, or secretary,
Yes,
chairman,
of
like
course.
that. So it is better to have election process. Everyone will be happy in that case.
So now
Anyone can
since
apply.
Yeah, I also
to
think
have
so.
before.
let's
I
go ahead
also
with
think
a
so.
yeah. So let's go ahead with a election right now. We have a
No,
time.
no, Vikas.
Vikas,
Circulate the
can I add
thing.
something?
Yes, sir.
Ravi sir, please go ahead.
No, no, you
Please
go ahead. You go ahead.
Please, sir. Acha. Just I wanted to add one thing. Instead of going for election right now, the reason behind is that whether our constitution allows it to go for the election right now is because we have not put it into the agenda. We have simply put the agenda as GBM. So we have not mentioned it that we are going for election this time. So is it okay, sir? Our constitution will allow it?
Yeah,
No,
Just a query. Just a query.
part of it is allowed.
Discussing the process.
Yeah.
Sir, we are just discussing only how to go ahead with this. We are not going for election right this moment. We are just
No, Jadu.
discussing only how to.
Yeah, Jodhu, I understand, but Vikas and sir was just discussing whether we can go into the right now or not. That was my query.
Yeah,
I'm not opposed.
Then
Jodhu,
you
I am
will
not
appoint.
opposing. I am not
Then-
opposing. I am just raising the query.
Then I'll just put one point. In that case, can you put a date, maybe 10 days, 15 days later?
Exactly.
And we have an online session only. Let us go
Okay.
online. All the members be present for 1 hour only, and we can have the
Right.
election during that 1 hour.
Right. Once you put a notice that at online date we are going to have a general body meeting and subsequent election, and in that meeting whoever is present, it is okay. Whoever not present, that we will take it granted that they are not interested.
And I think everybody can.
No. I think Dr. Path, that
Kalib, go ahead, please.
so that won't be.
Because in GBM, this process of selecting new committee is a part of our discussion always.
I do agree. But each time it was the physical meeting, and that during the agenda only we have that was mentioned that we are going for election. But this time we have not put
Hello.
out.
Yes.
Because Ashok Das here. Can I have a comment, please?
Yes.
So actually, we should take a decision on of a special GBM again, because GBM users cannot hold for. Okay, GBM actually done in general annual conference also. So let's have a decision today that we will have a special GBM after so and so time. And we should have a election committee also, and we should give some time frame for application for the different posts in the executive committee. And I would just like to make a request to Bhuyan sir that time has changed. How you people have started this organization, so we are standing in a different position now. So we should look forward, and we should really need to relook our SOPs. For example,
you
this
cannot
election
go ahead
process
in
and
the
all.
same way.
Exactly, sir.
We have to do it, and online is not a bad thing. Online has to be there because many of the members who are say outside the Northeast, and they are not coming. But if it is an online, they can also participate. At least they can vote. They can vote. So but it's a good thing. It has to be. Only thing we have not done, so we have to find out the modalities, how to do it, and it may require some time. Now, the thing is whether we decide today that we will have an online mode of election and do it after 2 months, 3 months, or before the next general body meeting, next annual conference. Those things has to be decided, and then who will be given the responsibility to conduct the election. We have to find out the election officer.
So
we can do it.
Those
We
are
can
the
do
two
it
things.
both ways, sir. We can do it both ways. We can either take a decision to call for an extraordinary general body meeting saying that the
Yes.
thing is election, and invite nominations right away and hold
Okay.
the elections like what we are doing, or
Yeah.
we can choose to do it online. So we can send out notes to everybody, get everybody's input and take a decision. In principle, we can say the general body approves holding an extraordinary general body meeting for this purpose if
Right.
needed.
Yes.
If we
Okay.
decide to do it online, then it goes online. If we decide to call for nominations and do it in a general body meeting, we have already approved the extraordinary general body meeting. So if required, we will do that.
Yes, sir. Exactly. I agree, sir.
So I think make this decision itself that we'll do an extraordinary general body meeting after 2 months. I'm just saying an arbitrary thing, 2 months. Maybe we can decide about 1 month also. And then one circular from the secretary should go that the general body this time has decided to ask for nominations. And these are the ways how to send the nominations. Now, nomination, whenever it will be sent, it has to be sent to the election officer. So decide a person to whom to send the nominations. The desiring person will send the nominations to the election officer, and he will sort of maintain that secrecy, and he will come out with the applications on the day of the general body meeting, and then it will be opened and they put to the general body and then take decision. Is it?
Dr. Bhuya,
Yeah,
why we need a general body to elect a committee? If we select an election officer or
he can do
1
it.
or 2 person, they can invite nomination, or and then through, as Ravi has said already, through postal ballot, election can be held.
Yes, I think that is also true.
Because holding
That
the
is also
election in a virtual mode, in a virtual meeting, I think will be little cumbersome.
Cumbersome, yeah.
So the
Will not end up.
election committee that you form today, that we can form in the general body, and the election committee will issue circular and then get the nomination. And if there is a prospect of contest, then they will decide about the mode of election. An alternative may be a postal ballot, if electronic becomes a little more expensive and all.
So, sir, we had already selected Dr. Kannan sir as a election officer. So
that you have to take as a resolution. Jagtap.
So I think that's
you write a resolution
that Dr. Ravi Kannan sir will be an election officer, right? Any objection to that? I don't think there is any objection. No.
You can put 2 people together, not only Ravi Kannan, sort of a committee, 2-man committee, Ritesh Sapkire from the same. Yeah.
Sir, I think if Ritesh wants to be part of, participate in the election process. So what we would say is, Dr. Ravi Kannan, with him being given the freedom to co-opt people to assist him. He will not be from association.
Ritesh is an executive member. Ritesh cannot be there.
Ravi, if he is nominated as an election officer, he cannot co-opt any member. The member has to be decided by the committee, the GB today.
The committee.
I think we can choose Pudu Same sir also. Sir, mine just.
I think that is fine. One more past president is fine.
Past president, sir, I'm thinking.
Yeah.
I want to add one thing, sir. Sir, one thing we need to decide at this moment only. If there is no participant, I mean to say, if there is no nomination for a particular post, then what we should do?
Yes.
Dr. Parth, what will we be doing all these years? That is my question. If there was nobody to...
No. So we are not going on that mode now. We are talking about now nomination filing.
That is why I propose that we can do the same process now. So it's not like every year.
Yeah,
that is the case. If you say that there is nothing in the agenda, then this year, without agenda, no GPM will be valid actually. If we as an association, we have not been following everything very strictly. So if this GPM won't be valid actually if we don't have a circulated GPM agenda actually. So since we are not been following very strict, it's a kind of not a very formal strict association, we can still go ahead with doing the same way now. Otherwise, this will keep taking ages and still nobody will be around to participate. That is my point.
No, we should have election this time. And if you know, I mean, if for a particular post there is no nomination, and then in that case we can ask for the person who is holding the post whether he can continue or not. Otherwise, I think the next executive committee they should ask someone for the particular post.
Yeah, I was
Because again,
exactly.
GBM we cannot have that.
Yeah, that same thing we need to take a resolution today itself, that this is so. If there is no nomination, we will ask this particular committee to continue. That is the thing. Just to take the resolution. Because at the end of the day or at the end of the election, we are not able to take this decision. Na? That is the only point.
In a committee, 2 members will be from outgoing committee and 2 members will be from the new committee. Will not be feasible. So if there is no nomination, then our member has to pursue somebody, persuade somebody ki yaar theek hai partha aap ye nomination bharo, or I propose your name, I propose so and so's name. So the member also can propose the name. That also we can do.
So okay, whatever may be the resolution
to
that
keep
needs.
the old member, I don't think that will look nice.
No, sir.
In that case,
I
mean
to say whatever is going to take the resolution, this to be taken today itself. That is my point.
A resolution we should
take
today
today
itself, but election we cannot have today.
No, election, not election. Not election.
We take the resolution, we
take
nominate the election officer, and then he will proceed, and let us see what happens.
Yeah. Joduda, you are into something.
Yes, I mean, for proposing again, if suppose there is no nomination for a particular post, in that case, we will have to have again one more CPM. That clause will be there for special CPM, I think, in our bylaws. It will be there. It is there.
And I think you should be.
There is a clause for provision for special CPM.
Dr. Bhuyan, we should not think that there will not be nomination. Why there will not be nomination?
Yes.
There will be nomination, but few posts may not be filled up. I tell you, I tell you one post which I'm very scared about is the post of the treasurer, which is so important, but it will be difficult. Or I have at least little doubt that somebody will volunteer to become a treasurer as such immediately. As such. I think still we make.
It's not a big this thing. We can pursue somebody. Why?
I think still we have to go ahead.
Why we are so
earlier this now it is much better for treasurer, I think.
Sir, now the treasurer issue. Yeah, now the treasurer will not be an issue. Everything is channelized. Everything is online. Everything is by check or NEFT transfer.
You are right, Vikas. We congratulate you. We congratulate Vikas for making the finance so smooth and so systematic.
Vikas and Jaddu, these 2 people had rescued the organization.
Sir,
it was a mess.
Everything has been done.
Gosabi sir and Bhuyan sir.
It's done.
Sir, moi just etai kotha kobo khudi asilu. Ami ebila kene complicated korat koi. Rather than this doing this complicated, আমি সিধা সিধি এতিয়া একমাহ সময় লৈ আমি সবকে পার্সিউ কৰি লওঁ কোনটো কোনটো পোস্টৰ কাৰণে কোন কোন এভেইলেবল আছে and then we don't go for nomination filing of the nomination আমি simply নাম কেটা ইলেক্ট্রাল অফিসারক দি দি এদিন পার্টিকুলার জিবিএম কৰি
মানে কোনে দিব এইটো কথা হলে
আকৌ আমি যদি স্যার নমিনেশন কৰিব বিচাৰো তেনেহলে আকৌ কোনোবা এটা খালি থাকিব কোনোবা এটা নিজে ইচ্ছা কৰি নিদিব পৰিব পাৰে
another thing which comes to my mind say can the members propose instead of asking for nomination can it be a proposal sort of thing say 2-3 names come from for the president then it will be election which the election officer will decide how to do 2-3 name comes for the election proposal
that has to be done now. Sir, if you want to do that way, you can do it now. If you want to do it after some time, then it has to be through a proper filing of nominations.
Yes.
Other people are silent. So 39 people are online. Are kuch bolo? Everybody, I request all of you to shout and not shout, just vouch your opinion. Munlima is sitting there, V. Kamo is there. And the names, let me read out. Ami ketamane koi asu. Nabin Nayan, Nripendra, Partha Medhi. Okay, Bhargav, Saikia, please say something. Abhijit Talukdar.
Sir, my
Debabrata Burman, Jyotiman Nath, Purjohari Medhi, please. Kwa.
Sir, মই এটা কথা কওঁ যে আমি এটা ইলেকশন কমিটি এটা গঠন কৰো and then give him them the full credit, let them decide how they want to take the election process.
Then
we have to
can
agree
also
with
be done.
Whatever they decide, we have to agree with them.
That's what I feel, that we make Ravi and give him 2 hands. Okay, Ritesh is there in the same building, so it would have been good, but he is an executive member. I cannot suggest his name. Polomi is not an executive member. She can be made a member. And another member like our Kudus Ahmed, as you have said. So make a committee of 3 and let them proceed with the speeches. And then we make a time frame for them to come back with resolutions, their decisions.
Will be much better, I think, sir.
Yeah. By March.
Kudus Ahmed sir, Ravi Kannan sir, aru Tomsa Singh sir di dile, I think 3 jone oi duniake organize kori dibo paribo moi bhabu.
Moi bhabu paribo. I think that is a possible thing, and they will be doing it for the first time for our association. And if this becomes
Tomsa sir aru Kudus Ahmed sir probably online nai, probably tonor consent eta loa to bhal niki
এইটোই কথা কদ্দু নাই না
Ravi sir ase
যদি নাই তেওঁক নালাগে Tomsa sir আছে নেকি
Tomsa sir
there?
No sir, he is not there.
Probably Indebar Singh was there. Jodi Indebar Singh sir lobo khuje etu dibo.
Indebar has left.
Okay,
find out one senior member. Ravi is there, Polomi is there.
Sir, Goswami sir is there.
Goswami sir. Goswami sir.
Yeah. Vivas Goswami, Ravi Kannan and
Polomi.
Sir, no potential candidate hobo pare chairman er karone Vivas Goswami sir.
Jiketa manu yate thakibo, they cannot become candidate.
Goswami sir will be saying ki I want to be member.
Goswami sir rasta bond kore dile.
So make a decision.
Past president sir, only past president sir.
Past presidents. So nai no yate kuno.
Na etu ami kotha pati phone kori lom aru sir kotha pati.
Committee, to make the committee decision has to be done right away.
Ejon to Kannan sir clear hol, baki apnalok dujone select kori dibo 2 more past president by chairman and secretary.
Put the name of Kudus Ahmed, I will convince him. Or put the name of Tomsa Singh, I will convince him. I'll phone him later on.
I'll call Dr. Kudus sir. I'll call him.
Call him.
In the meantime,
right
two
now.
names are final: Dr. Kannan sir, Pulomi, and I'll call Kudus sir. If he agrees, we'll go
No,
ahead.
no, don't put follow me, because if she wants to contest, then we will deny her that opportunity. I think what
She'll
Jagtap
be out.
says is correct. We
Sir,
should
then
include
I think-
3 past presidents. What I suggest is just say committee consisting of Ravi Kannan, because Ravi Kannan is here, and 2 other past presidents. I will find out how to do this. That's all.
Okay, sir.
All right, fine.
Yeah, that is
Leave
fine,
it on
Kudus.
to Ravi. Take this final decision. Okay.
So they
And the
will-
time frame, Ravi, you tell us. You would do it. You'll be able to, or you'll require 2 months or 3 months time.
3 months.
You tell us.
3 months.
Write that down. 3 months. Okay. Fine. Ravi
this is
Kannan
final,
is
so we will
with the
take it
election
as a-
officer, and he will take 2 more past presidents with him to conduct an election, either by ballot vote or by online mode. Okay.
So they will decide, sir. Whatever.
Yeah, let
They
them
will
let them decide.
Let them decide, sir. So we'll just
Let
resolution.
them decide,
today.
and it will be done in 3 months' time.
Yeah. as
By
per
end
the-
of April.
Okay, sir.
Yeah.
Kannan sir, this is okay now, I think.
Fine. So the election issue is an important issue which is done. Very good. We have given responsibility to responsible people. Okay. If Tomsa, Ravi Kannan, and Kudus Ahmed comes up, it will be very good. That's a good thing. Any more input from anybody?
And after that election, that committee's time period will be
2 years, as per the
2
last.
years. 2 years.
from the time of
Almost
they
2 years.
take the search.
Yeah, 2 years.
They will
Till then-
have to face 2 general body meetings and 2 conferences.
Yeah.
That's all.
That is being maintained for last years, whatever. Same thing.
Okay. It will be only 2-3 months beside their side. That's all. So you can go ahead. We can go to the next point in the agenda.
Next
All
annual
right.
conference. Next meeting.
To decide the next annual conference.
Yes, sir.
Anybody who would like to call the meeting into his place?
Sir, Abhijit was asking me for meeting at Guwahati. So Abhijit, I think you are there.
Yeah, I am here.
Yes,
so if no one is there, then we want to hold the next annual conference. That will be in the next March, I said, February, I said.
Yeah, next February.
Yeah. So
next end of January to end of February. You have to find out time. Okay.
Yeah.
Any objection from anybody?
No objection.
No, sir. No, sir. No objection.
Anybody who would like to contest this? If there is none,
before blocking it, I just wanted to say one thing. As because this year's logistic issue, we had to came out of Agartala. So during the last meeting only, we were decided to give him one more chance, preferably.
I think
if he is willing, sir. If he is willing.
He is not
he
there.
is not there on the meeting. Yeah.
So
So I think we decide.
Okay.
I only would like to give chances to anybody else who is in this line and wants to contest the Abhijit's invitation. Whoever is not present in this meeting, I think it will be difficult. So we feel very sorry about Agartala, but he has not joined the meeting.
Yeah. If it is not there, then probably we are not able to push him.
So then, if all the members keep silent, then Kwa.
Bhuyan sir. So more last
you can tell. BBC at last meeting, I think we had it in 16, Nikki?
No, 2019. 2019 we had
2019 last year. 19 last.
No, sorry, 18. 2018.
2018.
2018 we had an annual conference in BBCI. 2018.
Physical meeting hoise niki amar aro.
Yeah, after that 2018. Kohima, then Shillong, and in between there were small CMEs, other places.
Annual conference amar BBC told. Kohima
2018 দাদা
নাই,
লাস্ট
নাই।
হৈছে তাৰপিছত হোৱা নাই আৰু
2018 was the last. After that, nothing was held.
2019 we had meeting. 2020 we had physical meeting in Shillong.
Jodhuda,
2020 you did the meeting
for
in
your
Shillong.
information, we are not asking for BBCI. We are asking for Guwahati.
Then it's okay.
Right, Abhijit?
Yeah.
Abhijit.
Yes, sir.
Abhijit.
Hi, sir. Yes, sir.
Abhijit.
Yes, sir.
You understand, no? Some people are discussing regarding BBCI.
Yeah.
So will you be possible? Will it be possible for you to organize outside BBCI? Say for other people's sort of confidence or what?
Yeah, sir. Yeah, sir. Just 1 minute. It is not like that, sir. I just so last physical meeting yate hoisile niki just I wanted to know that.
Jodu, I'll tell.
No.
2018, the annual conference was held in Guwahati, B. Burwa Cancer Hospital. After that, 2019, we had an annual conference in Kohima. 2020, we had an annual conference in Shillong. After 2018 annual conferences, there was no physical conference held in BBCI, but it was held in Guwahati. One conference which we did was in Taj Hotel, which was breast cancer CME, and other conferences were done in different places. One was in Dibrugarh, then Shillong we had 2 conferences here, midterm conferences, Gynae, one was done by Dr. Kalib also, but not in Guwahati. Guwahati only you had one conference in between. That breast CME which was done in
আমি just rotate কৰি থাকোতো আমাৰ annual conference.
I understand, Jadu.
মোৰো এটো ইস্যু আছিল মই সেইকাৰণে ডিস কৰিছিলো আমি
No,
আগত দিব পাৰো নেকি মোৰো এটো ইস্যু
I
আছিল
don't know the process of how you allot the conferences, but if suppose this was a conference had to be held at Tripura, but because of some issue they could not take up. So if some other parts of the people are interested, I have no problem.
আৰু যদি কোটো নহয় তেতিয়া হলে আমাৰ অভিজিতৰ যেটো কৈছে will go ahead.
No. I think we decide.
We have to decide.
We decide now. We have to decide right now because we have sufficient members. And see, I tell
Gaurav,
you,
do you want to put
nobody else is inviting. Only he is inviting. So he has the right to call it, take it.
Yes.
He has the right to tell it. So as a president, let me open it up a little bit. Yes.
No, মই অভিজিতক খুদিব কৈছো the অভিজিতৰ invitation for the conference. It is
formally invited.
No, invitation
to
BBCI na Guwahati.
So actually I
decide কৰিব পিছত
decide কৰিব লাগিব স্যাৰ এটো.
They'll decide.
But as an organization, as a I think Gaurav also is there.
Nobody is contesting him, so it takes it. Yes.
But মই এটা পুট কৰি
you young people should take it.
মই এটা বস্তু পুট কৰিব খুজিম স্যার গোস্বামী স্যারক ক্লিয়াৰ কৰিব কাৰণে probably a meeting to BBCI ৰ কাৰণে কল কৰা উচিত নহব. I let it put at Guwahati, then venue can be anywhere else. Venue can be anywhere. But this is not an invitation from BBCI, to clear you.
Yeah, it's not an official kind of thing that.
Yeah.
BBCI.
Venue can be BBCI.
Because I have not taken any.
Dr. Abhijit wants to hold the next annual conference on his behalf at Guwahati. So let him decide where he wants to hold.
Yeah, exactly.
Any objection to that? If anybody is objecting that I want to put it in my place against Dr. Abhijit's proposition, then you can raise the hands. If not, then we'll go ahead with Dr. Abhijit's proposal that we will give it to him. He will be organizing the conference from his side, whether he wants to do it in hotel or BBCI, that is his decision.
Exactly. That will be decided by them.
So that
at the moment, Gaurav is supporting. That means Gaurav is there online, Partho is there, and they will be doing it.
Yeah, sure, that's fine. So next
year,
we
give it to you. This proposal.
Yeah, and Dr. Gayatri has made a proposal for a midterm CME in Assam Medical College because it's a partial platinum. But when do you want to hold it, madam? Which month?
It entirely depends on the situation. And this year, it's very significant for our college. It is our platinum jubilee. So we are celebrating for entire year till 3rd November 2022.
Okay.
yeah, it will. We will decide about the date, and
So
we
you
will all.
take, yeah,
Yes.
madam,
Yes.
গায়ত্রী বাইদেউ,
Partha. Yes,
ম্যাডাম
Partha কোৱা।
যদি আপনি ডেটটো ফিক্স নকৰো এটলিষ্ট মান্থটো কৈ দিলে তেতিয়া ভাল হয়, এটলিষ্ট এটা মান্থ এটা কৈ থৈ দিয়ক, যদি ফিজিক্যাল নহলে উই ক্যান
That will be
হ্যাভ
better.
ভার্চুয়াল অলসো
At a time frame, hoy Gayatri.
Yes.
At a time frame.
May, is it fine? May, month of May.
You say May and June. May/June. Okay, I give you one more month.
Okay.
To play.
Yes. We will mark it as a part of our celebration also. So I will propose to our committee.
Okay, fine. Great. But then it will be AONEI midterm CME. Okay.
Right. Yes.
Understand my point? It will be an AONEI midterm CME done during the celebration process of Assam Medical
Right,
College.
sir.
That's very good. That
Right,
will be
sir.
very good.
In collaboration with ANC. Exactly.
Yeah.
Okay.
Yes.
So
if physical not possible, then we can have virtual meeting also. There is no problem.
Any other?
All right.
Any other?
Try to make it
others?
physical as much as possible.
Yes.
Sir, for me, I would like to take one midterm CME by around November.
This will not be called as.
Who is speaking,
midterm
please?
CME. So this will be as a CME only, because midterm CME is taken by Dr. Gayatri. So you can
under
have the
CME.
CME in with
We can take by around November.
November 2020.
November.
June, July, August, September, October, November. Okay.
Nipendra, is it?
Yes, sir. Yes, sir.
Yeah.
Nipendra is calling, is it? Yeah. So
Yes, sir.
Nipendra, what is our experience in last 2-3 years is that the COVID surge starts from November onwards. So if possible, you come up little bit ahead, October, maybe, before
problem,
the
sir.
next COVID surge comes.
No problem, sir.
All right.
So we'll give
Okay.
October, November, 2 months, same like Dr. Gayatri.
We keep it October, November, and Gayatri is May, June. So 2 programs are finalized. I think, Vikas.
Yes, sir.
2 at the moment is good enough.
Yes, sir. For this
If
academic
anybody
year,
else wants to do,
at least, sir, for this academic year, I think 2 is sufficient.
Sufficient. But even then, I because Goswami sir is there, no? Dr. Vikas Goswami is there. Goswami da eta kiba nokore ki amar one program at State Cancer Hospital.
Amar the hall
CME or something.
Amar to hall nai. Amar gote
Oh, apni he dangor to nai bole no.
The construction activity is going on.
Okay. ठीक है. No issue. No issue. Anyway, we have decided 2. And
Hall
2,
means,
if we can do, is good enough.
we can have a small meeting room with around 50-60 capacity.
I think, sir, that option can be kept open. Whoever wants to conduct a CME can.
If you want to do,
if
you want to do that, don't. Yes.
Yeah. Then that will be decided at that time as per the situation and the availability and the gap between the 2 CMEs. Then we can take up it. Whoever wants to consent, just contact the
With a
secretary.
capacity of 50-60 people, we can arrange, no problem.
Enough. Because in this CME, then midterm CME, no? Midterm CME, the central people will also come. But for the CME that is done locally, these are meant for small focus groups. Say if it is done in Arunachal, the Arunachal people will only attend there. It is like that. So this type of a program
CME
can be done.
50 capacity হৈ যাব লাগে স্যার।
Good enough.
Time to cover niki. Time to দিব niki.
আপনি কক আপনার কোন সময়ত কিবা program থাকিব পাৰে, or you can let us know later on when you decide.
Okay.
আমি এই টাইমত করি। Okay.
I'll let you know.
This is flexibility is given to you.
Thank you.
So these 3 meetings for the next academic year. Done?
Yes, sir.
So any other issue? This is the last point in the agenda of the GBM. Anybody else has any issues to raise, to say? Even if you want to give gali to the president and secretary or anybody, you can put it here. This is your last chance in this year.
Sir, মই এটা কথা Bhuyan sir, with your permission, মই এটা কথা ক'ব বিচাৰো যে আমি এটা জাস্ট ফলো কৰিছিলো, যদিও CME এটা অৰ্গানাইজ কৰোতে আগতে আমি পাৰ্সোনালি আমি যিমান পাৰো যতে পাৰো সবকে ইনভাইট কৰিছিলো, কল কৰিছিলো যে এটো আমাৰ যদিও আমি আজিকালি গ্ৰুপত এভেইলেবল কৰো দিও, So is it really necessary or not necessary?
Yes,
To
Joduda
make that
Sabatka,
the member-
Joduda Atatka Agate Apunak Moy support Kuri. Because yes, I also feel that we are a small association. There's not many too many members are there. যদিও 150 প্লাস আছে মই এক্টিভ মেম্বার বোধ কৰো 70 or 80
70 80 থাকে
yeah, so I feel যদুদাক মই ফুললি সাপোর্ট কৰিম যে পার্সোনাল ইন্টারেকশন টু থাকাটো বোধ কৰো আমাৰ কাৰণে ইম্পৰ্টেন্ট
মানে এটো পার্সোনালি ইমেইল অর সামথিং লাইক দ্যাট
whatever maybe what you say email কক
আগতে
আপুনি
তো
WhatsApp কক পার্সোনালি ফোন কৰক কক
যদু জানে আগতে মই চিঠি বনাই সব ৰিপ্ৰেজেন্টেটিভৰ হাতত জেগাই পঠাইছিলো I used to send letters right you remember no
please
and you have a very good feeling when you receive a letter it's true even if you receive a letter today you'll feel good but that physical letter sending will be little cumbersome.
No, I am not asking about the physical letter sending. I mean to say
email.
head to head personal communication. That meaning either you WhatsApp or you can take up your phone, you can call, give a call, you can put a email. Rather
that
than
will be
rather
that will be the organizer.
Sir, rather than just putting a brochure and you will find to know that your presentation is on 29th October at 7 p.m. and you have to judge. This is looks some awkward to me.
Right.
This is my personal opinion.
No, that is a very good thing. In fact, it's a person-to-person attachment will be increased. Respect to each other is increased. Okay, bonding will be better. Camaraderie will be better. And this is what for the association stands. I always feel that working in BBCI, I was considered to be a sort of endowed person by my colleague who is sitting in Arunachal Itanagar. But then he should not be sort of feeling sort of an inhibition to face me or to contact me. There should be personal level of contact and a loss of inhibitions on the matters of patient management. And this will come if we contact personally, if we keep touch personally, even through these type of meetings when we see each other and talk to each other, making things open for all and then taking opinions from all. I think that's very true and very good. And the CME organizers, whoever organizes a CME, whatever possible, whenever possible, and as much as possible, please try to contact people and then inform. I know everybody cannot be contacted, but as much as possible, as Jodu has proposed, as Martha has seconded.
Not necessarily that same organizing secretary or organizing chairman phone karo, but anyone they can on behalf of them also someone can call. But amar eta jodi ami enekor rule past chairman bijanok jate at least secretary aro chairman as a kenebake holo that they should contact at least for a past chairman.
Chairman, president secretary.
President secretary, no, the past.
Past president secretary.
Past president secretary, at least.
Past president and secretary.
There should be a rule.
Moyo pap Jodu.
Dada, Joduda. Yeah. Joduda. Joduda. মানে কোনে কাক ফোন কৰিব হেতু কৰাতকৈ মই ভাবিছো আপুনি ধৰক অৰ্গানাইজিং কমিটি এটা ডেফিনেটলি ফৰ্ম কৰা হ'বই এই অৰ্গানাইজিং কমিটিৰ পৰা যোনে যাৰ লগত যাৰ ৰেপো ভাল হয় সেই হিচাপে ফোন কৰিলে হৈ যায় মই এটাই কথা ক'ব খুজিছো জাষ্ট অনলি পাৰ্সোনাল কন্টাক্ট হেড টু হেড পাৰ্সোনাল কন্টাক্টটো যাতে মেইনটেইন কৰে হেতুই মই ক'ব খুজিছো ইজ নট নেসেসাৰি প্ৰেসিডেন্টে ক'ব লাগিব এতিয়া ধৰকচোন আপোনাৰ লগত মোৰ ৰেপো যদি ভাল আপোনাক মই কমফৰ্টেবল ফোন কৰিম আপোনাক মই ফোন কৰি বাতি দিম দ্যাটস ওকে নহয় জানো
there are two things here Partho. One is what you have said and the other if what Jody is saying the organizing secretary of the committee will inform past presidents and past secretaries if and when possible no hobo pare but then effort will be given and this I think as a president of this organization I can appeal not as a resolution. This will not go as a resolution but as an appeal
Yes, now মই ইয়াত এটাই কেভিয়েট থাকিব পাৰে মই এটো কাৰণে ক'ব খুজিছিলো ফৰ এক্সাম্পল কোনোবা এজন পাষ্ট প্ৰেসিডেন্ট যাৰ লগত মই সেক্ৰেটাৰী নহয় কিন্তু মোৰ ধৰকচোন পাৰ্সোনাল ইন্টাৰাকশন বেছি ভাল তেনেহলে মই যদি বেইং ইন দ্য অৰ্গানাইজিং কমিটি মই কৰো ৰাদাৰ দেন অৰ্গানাইজিং সেক্ৰেটাৰী তাৰ লগত যদি ইমান ইন্টাৰাকশন নাই কি প্ৰবলেম প্ৰবলেম হ'ব নালাগে
মানে that organizing secretary will use his friend to contact the person.
This is what you are telling, that is correct. But মানুহ যদি কয় যে মই অৰ্গানাইজিং সেক্ৰেটাৰী AONEI annual conference পৰা কৈছো স্যাৰ আমি so we are organizing, that will be more I think justified and from my side, because he is the organizing secretary. He is organizing secretary of AONEI annual conference. Tomorrow you might have that personal touch with that particular person, but on behalf of the annual conference, he is inviting the past president.
Secretary is not a responsibility আছে
মই বেলেগ কোৱাই নাই মই কৈছো অৰ্গানাইজিং কমিটিৰ এজন মেম্বাৰে ফোন কৰিব organizing committee.
But I just wanted to ask when this happened, I had called personally to all of you almost to come and join. Personally send a WhatsApp link.
Good.
Yeah. So why this issue is arising?
Exactly.
I am not getting why you are
used to call. Dr. Vikas used to call every
everybody,
time.
I had called everybody.
No.
Yes, exactly.
But this issue will never arise. Whoever is organizing the conference, they will always call the person before ki this is of course Jodu, I called you also, you were the initial speaker, but then you said I was busy, so I told you ki you continue, but just join whenever you are
busy. I was not well actually those days.
Also it never happened. That's what my point is. In the past meetings also it has never happened. Always the organization.
I am not telling about you, just this I mean we should know, that's what I am telling.
Because
if anybody is missed, if I am not the president secretary tomorrow, if anybody is missed, I will make sure that I will call the president and secretary.
President sir and secretary মই কিবা এটা পয়েন্ট ৰেজ কৰিব খুজি আছো.
Yes
sir. আচ্ছা next step পৰা when we are conducting this annual conference এর কাৰণে এটা scientific committee বনাও. So মই ভাবিছো এতিয়াৰ পৰা যিকেটা scientific committee মানে যিকেটা organizing committee আছে সেই organizing committee member কেজন including one member or two member from the executive committee, scientific committee আগতে হদিলেও ভাল নেকি?
Not by the general body.
I'll just clarify this issue. So this issue was done already in the conference which was held in Guwahati when Jodu arranged a conference in, I think in Pan Bazar there was some hotel.
Pan Bazar hotel.
Yeah. So this time we had already clarified that the committee will be finalizing the scientific program wherever the conference is going to be held, whether it's in Guwahati, Shillong, Agartala, wherever. And the liberty will be given to the organizing secretary to have more of a local people in the committee and as a speaker, as a chairperson, as a panelist. But the scientific program, what is the content, what is the topics, will be finalized by the central committee. So that scientific committee will be a total central committee of AONEI, including the president, secretary, advisor, anybody. Of course, now it's not easy to get everybody consent. Even if that is sent to secretary, president, and some of the member, that is okay. Like what we did for the even Agartala or what we did for the Shillong conference also, I circulated to you. So that has been already discussed and it is already in place. We don't have to put it again. So whoever is organizing the next conference, they have to send the agenda
because why I did put up this issue is we don't have any formal scientific committee in the executive I mean to say in the executive members, right?
In that meeting we decided that the whole central committee will be acting as a scientific committee. That is what
Bhuyan sir and Vikas, in our ASA we have two vice presidents. So one vice president works as scientific committee chairperson and other vice president works as the social activities chairman, like that. And that vice president, he forms the scientific committee group. That is in our ASA group. I don't know.
But then we have to change the constitution again for a second vice president. So I think what we discussed in the last meeting. So in the meantime, we can just continue. They have to send to the executive committee members. There is already a group now. And if everybody is okay, we'll go ahead with the format. I don't think that there is any need to complicate this more. The organizing person has to send the program to the
Yeah, I think
so the AONEI team, AONEI Central Committee, which is their president, secretary, advisor, and the executive member from all the states, and they, if they approve, that will be go ahead.
No, otherwise,
Yes, yes.
Because
Yes.
otherwise all responsibility comes to the secretary. If you have a scientific committee, then he can take care of the scientific part actually.
That's
Because
why
the
I'm
secretary
that's why I'm also proposing to create a scientific committee. Can have 1 or 2 members from the executive board, and then
long time back, I think 6-7 years back or more, Kudus Ahmed, myself, Ravikanan, we were made a committee for something. What for was that?
So that time
Scientific
in the
committee.
same conference, so Dr. Ritesh, then you were there, Dr. Kudus sir was there, Dr. Ravikanan sir was there. So that was a scientific committee, but later on in the subsequent meeting that was dissolved, and we decided that the central committee will act as a scientific committee to decide about the topics.
But so what we can decide, what we can make. So, in this issue, if we take it to make a decision, can we decide that the local organizing committee will have the liberty to, sort of making the scientific program, and this has to be approved by the central committee. The central committee will be by the secretary and the editor of the general body. No, sir, editor is always doing a scientific work.
Sir, I will propose that you will meet a scientific committee, separate scientific committee, constituting of 1 or 2 members of the existing executive members. Whoever is there, I don't have any
issue. It has to be two or three members. It should not be one member.
That's okay.
It should not be one member.
No,
so the secretary remains involved, because secretary will have to have a lot of responsibility. So secretary and the treasurer. Okay, sorry, and the editor.
No, I think the secretary and president should not be there.
Sir, let the assistant secretary take up that. Assistant secretary and website and newsletter in charge. Assistant
Instead
secretary.
of names, make it ex officio. Ex officio. Okay, fine. Secretary president apart.
Yeah, secretary
maybe the editor and the.
So we'll take up the scientific committee.
Maybe vice president and editor.
And also I will insist to select such members that at least we can represent 2 or 3 specialty. Not like that all radiation oncology, medical oncology, all surgical oncology. Then it will be biased. It will be biased.
On the member who is selected.
Just try to understand my point. I am not against anything. I am just opening up all the aspects.
I think this is okay. Vice president, advisor, assistant secretary, and the website in charge, 4 will be the members. That is okay.
And now how will you decide?
Yes, I think
this committee is the central committee then.
No, these people
they will, in consultation with the local body, they will decide about the scientific program, right?
Yeah. So vice president, advisor, assistant secretary, and website in charge.
All right, fine. 4 people. If they can, 3 of them can unite or have sit together, they can make it done. So this is the last resolution.
Give them the freedom to elect, to co-opt suitable members from other specialties.
Yeah, that is
See what Partho said is correct. If you have
exactly, it should have representative of all the experts, right, sir?
Yeah. So let the committee, whoever is in the committee, co-opt people and declare it before the meeting is done. That's all.
Yes, sir.
That's done. Very good. So take it as a resolution. Last resolution.
Document.
So I think we have decided a very important thing was decided on any other issue, and we have come to the end of the general body meeting. So any more programs after this?
Sir, just the result declaration and
nothing much. I think I thank you all for being in the general body meeting, giving input. Somebody has spoken, somebody has given in the text box. Very good. I think we made a threadbare discussion, and we really want to go ahead with election and election of a new committee, new president, secretary, treasurer, editor, and new blood into AONEI. Ravi, please take the initiative, and we want to see it done by the before the month of May, right? So with this, I thank all of you. I thank Vikas Jagtap for his effort, and you should all give him a big hand claps for his effort to running this organization so smooth for last over 4 years, and especially regarding this conference, the issues that we face since the month of October, I think. And finally, it's done today by his effort, I should say, and Caleb and Ritesh, of course. The main, he is in contact with these two people there, and me, of course, in Guwahati being the president. Thank you all. So we finished this general body meeting for 2022, and we move on to the last of the agenda. Result announcement and vote of thanks by Dr. Partho Roy. Thank you very much.
विकास,
yes.
तो लिस्ट तो तुम्हारे पास ही है ना, कर दो, मुझे बोलना है,
Anyway,
कर दो, हाँ कर दो, तुम्हें खत्म कर दो.
so for the competition, just 1 second. So for the poster competition, we had, after many suggestions, we made it separate. Those who had case presentation, we had a special prize for the case presentation. But as a main poster, the 3 prizes are given. The first prize goes to Dr. Megha Nandwani. She is a junior consultant in Dharamshila Narayana Super Speciality Hospital at Delhi. She was initially a fellowship student at Bibro Cancer Institute, Guwahati in Gynae Oncology. The second prize goes to Dr. Dhiru Talukdar, who is the final year MD Radiation Oncology resident at Bibro Cancer Institute, Guwahati. And the third prize goes to Dr. Roma Jethani, who is a senior resident at Gynae Oncology in BBCI, Guwahati. The special prize for the case presentation session goes to Dr. Apurva Tak, again a MCH trainee from Gynae Oncology at Bibirwa Cancer Institute. And for the quiz session, which was held today, we had a tie for the first place and second place. So we'll be announcing the first, second results only. For the first place, we have Dr. Shashank Bansal, who is now doing a DM medical oncology at Indore. So he is the first prize, along with Dr. Dhiru Talukdar. Both got 24 points. So Dr. Dhiru Talukdar again has got a second prize in poster presentation. He has got a first prize. So both of them are sharing the first prize with 24 marks. And the second winner is Dr. Chandrasekhar Vihari from BBCI Guwahati. I think he is a surgical oncology MCS student. And Dr. Janabi from State Cancer Institute, Guwahati. I think she is there or no? I think so. Second prize is commonly also shared both by the Dr. Chandrasekhar and Dr. Janabi. So I request all the winners to contact that aoneioncology@gmail.com. Please share your account details with IFSC transfer NEFT details. The prize money, which will be decided later by the committee, will be transferred directly to your account, and we'll receive the certificate also. All the so just to make a small announcement, we have applied for a point to the Assam Medical Council also regarding this conference.
Yeah.
But the council said that you have to have a 8-hour continuous online session, and our all conference were divided into 4 hours, so they didn't allow it. They said if you want to hold online also, you should have a whole full day of 8 hours in online session. So that was not possible, so we couldn't get the point, but everybody will get a normal certificate will be given to all the people. Those who had not registered but attended the conference, just WhatsApp me the name and it will be uploaded for the online certificates. Now I hand over to Dr. Partho Sarthi Roy, our Assistant Secretary of AONEI, for the closing remarks and the vote of thanks. Partho, to you please.
Hello.
Yeah, Partho.
Okay.
Yes, you are there.
Okay, thank you, Vikas. Now, after a 3 days marathon race for this 17th annual meeting, we have came to a end of this meeting. Although unfortunately we are not able to perform it at physical platform, but we have completed 3 days marathon race for this virtual platform. Yes, unfortunately we are not able to apply for this AMC credit point. Because of this, we have divided it. For the next time, probably we have to keep it in mind that we can have a 1-day program for our total 8 hours. Anyway, so big thanks to all of you present who are present here and who might have left. So first of all, I would like to take the opportunity to thank our acting president, honorary acting president, Dr. C. Bhuyan. Without his own effort, it would not have been having possible. And next, probably a big thanks goes to our most energetic and most enthusiastic, my dear friend Dr. Vikas, who is as honorary general secretary of this session and also organizing secretary of this 17th annual meeting. And thanks, Dr. Vikas. And beyond that, I would like to also congratulate and thank all the members who were behind Dr. Vikas for making it a successful one. And I'd like to thank all the speakers, all the panelists, all the moderators who are from the local northeastern states, as well as from the outside Assam, to make this meeting full, delightful of scientific agendas and also sharing their own thoughts despite of their busy schedule. And at the same time, I would like to thank our team mighty duo, Mr. Ravindra Purohit, for making this event uninterrupted from this electromagnetic point of view. And in addition, I would like to also thank our sponsors who had provided some financial support for this conference. And most important, I'd like to thank our student friends to come up with a very good response. As we have seen on the day one, we have 21 presentation, either case presentation or paper presentation. So it is a very good response from the postgraduate students, and so as from the quiz part is concerned. So please, students, keep it up. It's a very good response from you. And probably with this much, I would like to once again thank you all. Thanks Vikas, thanks Dr. Bhuyan sir, and thank you all once again. From this much is from my side, and with this much, I would like to conclude this 17th AONEI